put the right tab on. My mother. All right. Good. Gynecology. Amusingly, this is not very different from what we learned in BLS, but of course, this is probably not covered great in BLS because it's also not covered great in things like sex education. I cannot begin to tell you the number of women who have no idea how their body works. Um, Things such as birth control, right? You can't just take birth control when you're going to have sex. Like it needs to happen continually because you're screwing up your hormones to make sure that you don't get pregnant. Um, so starting with the basic anatomy, right? Yes. I mean, yes. I don't know. It was pretty immaculate, wasn't it? Actually, the funny part about that is you can actually psychologically convince yourself that you're pregnant and start showing even though that there's nothing there. Um, it's one of the more curious psychological diseases, where if a woman can mind over matter it so hard that she actually changes her hormones to develop pregnancy hormones. Um, just absolutely wild.
There's that, and then not only that, but like nowadays, like you don't even need a man anymore. You don't even need sperm anymore.
It's true. And uh, even if you do everything right and you use birth control, you can still get pregnant because it's only 99% effective in the best of times. Because there's always user error. Um, and you want to talk about the new Texas abortion ban, most women don't even know that they're pregnant at 6 weeks. So unless you're constantly taking pregnancy tests, which again is also not necessarily 100% accurate because you can, still have a negative pregnancy test if you don't have enough of the hormone, which by the way, let's just skip right to that. Pregnancy tests test for human growth hormone, which is usually only present in the event of pregnancy. But if you're doing some sort of shady drugs, like bodybuilding and stuff like that, Gary, you should be biking. If you're doing anything that has synthetic human growth hormone, it could throw it off. Or if you don't have enough human growth hormone, it won't necessarily pop. Uh, but again, at the same time, pregnancy tests also can identify um, testicular cancer. If a man on a pregnancy stick and he gets it positive, he's strong likelihood that he has testicular cancer. So like, you know, science, we did a weird thing, right? We kind of have a hard time actually identifying what's going on in the human body most of the time because people are just crazy. Anywho, so here's the basics, right? So everyone's familiar with the vagina. That is the external opening to the world, or as they like to put it in the textbook, I believe it's called the receptacle for the penis. Which in the grand scheme of things is not accurate because it's actually an escape for menstrual blood. Let's not make this about men. Um, then you have the uterus, right? The uterus is a pear-shaped, pear-sized organ that usually kind of sits in like this posterior position, right? So you see the anatomy, you have the bladder, and then you have the uterus that kind of sits over it. Okay, most of the time it's very small. Okay, until you start putting babies in it, and then it gets really big and scary. The uterus is an extremely muscular organ. So this is why women have what's called those Braxton Hicks contractions during pregnancy, is because that muscle is starting to kind of figure out that it's going to have to do some work, and it's kind of like it's flexing its muscles. On the top of that, of the uterus, right, so you have the fundus, which is that part right up at top, which it can be palpated throughout the different stages of pregnancy. Then on you have the arms, you have the fallopian tubes, which are probably my favorite thing to articulate during anatomy. The fallopian tubes do this. And then you have the fimbriae, which are these little fingers, because the ovaries aren't actually connected in like the sense of like there's a solid tube to the fallopian tubes. So this is why ectopic pregnancies can happen outside of even the fallopian tube, is because they kind of float around in this weird like space dock. Okay, so like you have the fimbriae, and then you have the ovary, and the ovary will release an egg. And the fimbriae will like come to me, and do like its full on Dracula pull, and put it into this fallopian tube. Now most of the time, let's see how my doodle's feeling today. Probably poor. Most of the time, fertilization happens around here, okay, because you have a one cell ovum. See a little cute little bad boy right there. And it gets when it gets fertilized here, that's when it starts to divide. So as it starts to divide, um, further down in the fallopian tube, it should be implanting somewhere in this third of the uterus, okay? Because if that fertilized embryo uh, implants lower, you can have issues with placenta previa, right? When the placenta goes over the opening of the uterus, called the cervix, okay? The cervix is the gatekeeper to the uterus. When a woman goes into labor, that's what dilates or defaces, okay? It becomes very, very thin, and that nonsense opens up to 10 centimeters. Just go watch. There's a video like that shows like the different, it's like a wheel with all the different dilations, centimeters. 10 centimeters is huge. 10 centimeters is like 5 inches. It's like this big, right? um no, gentlemen, no one is that big, so no, a woman does not know what that feels like until she is given birth. And frankly, that's terrifying. um Absolutely terrifying.
Really not that bad. It's not, I
Well,
swear.
because you get the hormones that make you forget how bad it is, so otherwise the human race wouldn't
It's not
freaking
that
survive.
bad.
I know, there's things in this life that I would like probably love to avoid. Also C-sections. I don't know if anyone's been to labor and delivery and actually seen a C-section, but that is barbaric at best. Um, yeah, ugh. That gave me shivers for a long
Yeah,
time.
I'm telling you, as bad as the pushing the baby out part is, the other choice would not have been good. No,
No, no, no, definitely
no.
not. Like they just they don't even like use the scalpula. They like or the scalpel very effectively. Like the one time I saw it, they were just like ripping, and I was like, "Why you have a goddamn knife? Use the goddamn knife." Anyway, so that's your basic female reproductive system. Gentlemen, you're probably way more familiar with your reproductive system because it's on the outside, and you get to touch it way more than everybody else does. So, for the most part, um, yeah, the C-sections are good in so much as like it has significantly reduced fetal maternal death, because, but at the same time, it is also, we'll talk about this probably in a little bit. I believe it shows up in OB. It has also created more complications because, right, Darwin, right, the theory of evolution, where if a baby can't be born, it can't pass its genes on. So babies with big old Lego heads that don't fit out of a standard vagina aren't going to be born, and that genetic material isn't going to be passed on. But now we do C-sections. So that means that these big old blockheads are being born and passing those genes on, making C-sections more necessary. And then on top of that, you have the issue when you have doctors who are like, well, I have a golf day that day. I really don't feel like possibly coming in because you're in labor. Like, how damn inconvenient that you decided to go into a line of medicine that is relatively unpredictable. So they start just doing C-sections, and they'll tell women like, oh, well, you need the C-section because your baby's too big, it's not going to fit, or your baby says. I had one friend who they told her that she needed a C-section because her baby was going to be 8 pounds and wasn't going to fit. Her baby ended up being 5 pounds. That's, in my opinion, a significant difference. Okay. And so they kind of stole her opportunity to actually give birth naturally, which, not that that sounds like a better option, but at least you didn't have to have major abdominal surgery. Just my thought. So anyway, the normal menstrual cycle is traditionally thought to last about 28 days, from puberty to menopause, right? So the normal menstrual cycle, when we say puberty, in the United States, puberty has been, uh, yeah, C-sections. I go. Puberty has been coming earlier and earlier. where girls are having their menstrual cycle starting as early as 8. The problem is the earlier you go through menopause, through menarche, right? Menarche being the first. Let me see if I can. Probably on another slide, but I've said it now. So menarche.
First period.
First period. Like a butterfly. Sure. So the earlier a woman goes through menarche is the earlier that she starts menopause. And if you remember during our cardiovascular lecture, the moment a woman goes through menopause, her risk for cardiovascular disease matches that of a man of the same age. So you, as a female, are protected by estrogen. Estrogen is a fantastic hormone that does a really good job of keeping you a little squeaky cleaner and healthier in the cardiovascular department than those who primarily decide that testosterone is their way to go. Or as I like to call it, owners of ovaries or owners of testicles. Um, Gender is a hot topic now. And you're seeing a lot more people who are switching. So generally, over the course of every 28 days, the woman will have a cycle that lasts anywhere from 3 to 7 days. Okay, a woman will know what her normal cycle is. Okay, a woman can still have a normal cycle if pregnant, because sometimes the body's like, hey, hi. But yeah, so usually anywhere from like 3 to 7 days, there will be a free flow of blood from the uterus through the vagina to the outside world. It is approximately 25 to 60 milliliters of blood. So if you go look at an amp of bicarb, okay, that's 50 milliliters. That 50 milliliters is about how much fluid, but it's being spread out over the course of almost a week. Okay, so if a woman's saying that she's bleeding heavily and that's not normal for her, take that seriously, because you can't do anything for a gynecological hemorrhage, right? We can't put pressure on that. You can't pack a vagina, never pack a vagina. In the ambulance. What you do at home is your own thing. So kind of have an idea of how much fluid that's going to be, and it's not just blood, it's also some like cellular debris, could be a little bit of tissue, could be some clots. Hours of fun, right? A normal tampon or pad can absorb about 5 milliliters of blood. So if a woman says that she has gone through 4 tampons in the last hour, that is 20 milliliters of blood, and that is heavy menstrual bleeding. Okay, especially if that's not normal for her. If she's bleeding through a pad, okay, that's not normal. So, you know, keep in mind about how much blood is being lost, because again, like, you ask mom and dad about how many diapers a baby's going through to make sure they're hydrated or not, right? Or if they're having really bad diarrhea. Know this number so that if you're dealing with someone who's having a gynecological bleed, that you can kind of approximate how much blood has been lost if it's over that 60 milliliter kind of frame that you would anticipate. Again, this kind of goes out the window a little bit after in a postpartum woman, because after that she is getting rid of a lot of blood and debris and doing a full uterine cleanse because she has just given birth. So it's just a different story. You need to have some level of context for it, but a standard period shouldn't be crazy. Another important note, because this is not, I don't think, in my opinion, covered well in a textbook or even in sex education. A tampon should be changed every 4 to 6 hours. Okay? If not, a woman puts herself at increased risk of developing what's called toxic shock syndrome. Color. So a menstrual blood does have a variation of color, so it can be bright red. That means it's relatively fresh. It can be dark. Dark blood means that it's probably just older blood that is from a previous period that maybe wasn't cleansed fully. As long as you don't see any like purulent discharge, okay, which would indicate an infection or um, other kind of like funny looking discharge, it should be kind of blood. A little bit of mucus is normal, but it can range from anywhere from bright red to dark red, like a dark brownish maroon. Clots are also relatively normal. Some women will have more clots than other women, depending on what their normal flow is. But in regards to tampons, they should be changed every 4 to 6 hours. This toxic shock syndrome is something that's really not, in my opinion, taught well enough, especially in sex ed, because it can kill you. Right? The cotton from the tampon can hold a lot of bacteria. I believe it's Staphylococcus, is what you're essentially potentially putting into an open mucous membrane. Okay, and if you don't change that regularly, infection can occur. There's been women who will develop toxic shock syndrome. Basically, the signs are the palms of your hands and feet start sloughing off, okay? Very high fever, unresponsiveness, okay? And it's all due to tampons, because who knows what they're putting in tampons, because there's no FDA regulations on the contents of a tampon. So you're assuming you're getting some cotton, but hey, you never know. This this issue is usually relieved by alternative menstrual products such as discs or cups, but again, those things need to be changed regularly. So if anyone has a daughter in the future, make sure that you get her proper education on how to take care of her body, because they don't do enough in school. Similarly, a lot of people have no concept how hormones work. There are two main hormones that dictate a woman's menstrual cycle. It's estrogen and progesterone. Okay, so your follicular phase is when the follicle in the ovary starts to develop in becoming an egg, okay, into an ovum. Day 1 of the menstrual cycle. So when the first day she starts bleeding. So her body's like, oh, it's time. All right, we're going to redecorate the uterus. We're going to get a new egg in there. We're going to see if we're going to make a baby. Like, calm down, chick. Not today. So as the hormones are kind of relatively equal and stable throughout the first phase, this ovum starts to develop. And then when ovulation occurs, you have this big spike in both of those hormones. Okay, so both of those hormones are elevated. The ovum, usually the ovaries take turns each month. So like month 1, it'll be the right ovary will release an ovum. Month 2, it's the left one. This is how twins are born, because sometimes both ovaries are like boom, and you're like, no, too much. So as the ovum starts to produce, it starts to produce extra estrogen and as well, and this is what helps spike, and it's released, okay? And then it's released into the fimbriae, into the fallopian tubes, and it goes right, and it gets sucked into the fallopian tube, where if you are sexually active and not using protection, it could become a fertilized egg and therefore a baby, okay? If it is not, the hormones drop, okay, because if that egg is fertilized, it starts producing its own hormones. If it is not, you enter into the luteal phase. Okay, so in the luteal phase, you have about a week after from when the egg is released to the egg traveling through the fallopian tube, where it can become fertilized and pregnancy is a possibility. You have a big spike in progesterone. Okay, so this is why this is why birth control pills work, because birth control pills usually rely on progesterone, because it brings that hormone level up and it makes the body think that it's either pregnant or in menopause, because those two kind of look similar, but it's then the estrogen that kind of balances out. So if your body thinks, hey, we're good, we don't need to do anything else, we don't need to release an egg because we're here in this luteal phase. That's how birth control tricks your body. It makes it constantly think it's in the luteal phase, where an egg has been released and it's waiting fertilization. So it's not going to create another one, because that needs more estrogen on the other. There's also luteinizing hormone, which is, there's a whole bunch of hormones going on there. So as it moves through, if it does not become a fertilized egg, it goes through the luteal phase, and then we start going back to the beginning of the cycle, where menstruation occurs. And it obviously is a 28-day cycle. here's another picture. Your pituitary, your anterior pituitary gland helps moderate this cycle as well by also secreting luteinizing hormone, follicle stimulating hormone. Right, the follicle stimulating hormone, as that starts to increase, that's what triggers ovulation as well. Okay, so it's a play of um, these four different hormones, and they do also split it beyond being in the follicular phase and the luteal phase as the ovarian cycle, right? What's going on in the ovary, and the uterine cycle is what's going on in the uterus, right? So the uterus starts to, it'll shed the lining, and then it will start building the lining back up in preparation, and then go back down, whereas it's kind of coincides with the follicle developing, the follicle being released, and then the follicle not becoming fertilized. The ovulation tends to happen around 14, with day 1 being the day of the period. And this is how a lot of those quote unquote natural cycles, like it actually is like an app, like the Natural Cycles app. A lot of how these natural birth control apps and such work is because they track your period, and then they give you a general idea of when is not a good idea to have unprotected sex. So while the egg is usually available for fertilization for about a week, semen also has its own lifespan, which I believe is about 3 days. Okay. Semen has a little bit of sugar at the end that helps it give it mobility because it powers the little tail. So so the follicle becomes a corpus luteum, which also, we talked about that already, secretes more hormones. So the cycle continues. Okay. A woman is born with every single egg that she will have within her lifetime. It's about 300 that will become what you'll call it, matured and then released. Those follicles can also turn into cysts if they do not degenerate properly, and then you have the risk of having ovarian cysts, which are extremely painful, and if they are large enough, can actually cause the ovary to twist on the fallopian tube and cause an ovarian torsion, which is very similar to a testicular torsion, but much less likely to be taken seriously because women don't experience pain. All right, so you have a number of different hormones, right? We talked about the follicle stimulating hormone and luteinizing hormone, which are secreted from the anterior pituitary. Your ovaries do estrogen and progesterone. The endometrium also participates in this this phase, and the hypothalamus. Okay, and the hypothalamus is also controls your body temperature, which is why when women are ovulating, they have an increase in their body temperature. Okay, because the hypothalamus gets involved in that game. We talked about this already. Proliferative phase. This is when the uterus is prepared to accept a fertilized egg. Estrogen is primary here. Secretory phase is right after ovulation, and it continues, right? So like you were building it up in the proliferative phase, you're proliferating that uterine wall. The secretory phase is extra hormones that is saying, hey, it's time, ready, implanting that fertilized ovum. Nope, okay, and then it goes down to menstrues. 6 to 24 hours is how long a unfertilized ovum can survive. However, we get about a week worth of possibility for being fertile because we don't exactly know. Most of the time, women don't usually know when ovulation occurs. Some women have a relatively painful ovulation where they can tell you, oh, it's time, and that pain is called Mittelschmerz, which is one of my favorite German words. And Mittelschmerz really just means pain of ovulation. There's like a very like a twinge, and you can feel like that follicle being released. If fertilization doesn't occur, again, we talked, your hormone levels balance out and then menstruation begins. Question, thoughts, concerns. Be familiar with the 4 hormones. You don't necessarily have to know when they pop up exactly, but you should be familiar where they come from. Excuse me. Where they come from and that they're involved in the normal, oh, I missed the guard pill entirely, the normal menstrual cycle. Questions? Sweet. Pregnancy should always be considered in any woman of childbearing age. Average age is 12 to 51, but that does not mean that you will not or cannot have women who are pregnant younger and older than that. A woman or female, I guess, girl can become pregnant before her first period. So a young girl who is maybe a victim of sexual abuse, child brides, or whatever is going on in that awful situation, if she is sexually active and using and having unprotected sex at an age and times it just right where her first her first ovum is released during that period of sexual activity, she can actually become pregnant without ever having a first period. It's happened. Probably not a good thing. It's probably very indicative of child abuse. Just saying. So one of the issues that you will potentially see in an emergency setting is pelvic inflammatory disease. So pelvic inflammatory disease is like this generalized term for any sort of infection within the female reproductive tract. Okay. Usually it starts within the vagina, right? Because it's a point of access and will ascend throughout. If it is untreated, it can cause a lot of problems. Most of the time it's caused by gonorrhea and or chlamydia. And there is purulent vaginal discharge with an odor, usually like a fishy smell. There will be potentially abnormal bleeding, okay, because now you have this infection kind of messing up the endometrium, and very painful with intercourse, as well as pain with ambulation. So you'll see what's called the PID shuffle. Um, a woman will be bent over, right? Because if you bend over, you're calming your abdominal muscles, and she'll kind of shuffle because all of those hip flexors and the psoas and those muscles that go through that pelvic region are going to be inflamed because of this infection. So the problem, a further problem with PID is that a woman with PID has a increased risk of having ectopic pregnancies, okay, because all of this infectious material blocks the fallopian tubes. It also causes scarring even when it is being, okay. Usually this, because it is an infection, there will be an elevated temperature consistent usually with infection. A Bartholin's cyst, okay, may or may not be infected, but there's Bartholin is this it's a gland on the in the vaginal region that actually helps lubricate the area. Okay, remember, vaginas should not be dry. They're relatively moist locations. And if that gland gets blocked, it can turn into a cyst. And if it gets blocked and infected, it becomes an abscess. So there might be a visible lump. It might be painful. It might cause some discomfort. This is something that can be handled in an outpatient kind of setting. They just pop the cyst and drain it. But if someone's complaining of an uncomfortable lump in the vaginal region, that's be it. Vaginitis is an inflammation of the vagina that usually is caused by some sort of infectious cause, can be caused by a non-infectious cause. Most commonly, vaginitis is caused by a yeast infection. A woman's vagina is a very carefully balanced pH location. Okay, sex, all sorts of, you know, what's the word? Soaps, etc., can kind of screw up a woman's pH and can cause yeast to proliferate. Most of the time, a vagina is acidic. In case you were wondering, sperm is basic. That's the funniest sentence I think I said all day. So, um, most of the time, there is yeast living in that region. So, if the pH gets kind of skewed, that yeast will proliferate. Bacterial vaginosis also, if her sexual partner is not particularly good at cleaning his um, penis, then you can introduce bacteria to this location, right? And then if not proper, like the vagina does a good job of kind of self-cleaning, but sometimes that bacteria can get in there. Inflammation can be kind of vague. It might be some itchy, burning, or itchy discomfort in the area, burning with urination, could be about awful odor, or it could be almost nothing. If it's like an interior yeast infection, a woman may never know that she's actually has a yeast infection until she goes for her annual checkup. Post-menopausal and postpartum women have an increased risk of this because of those hormonal changes, right? They're screwing with everything in that general region. Postmenopausal women also have a lower um, moisture level because of the loss of estrogen. So that also doesn't help kind of with the self-cleaning process of that the vagina uses. So we have dysmenorrhea. Okay, is a very painful menstrual cycle. Menstrual cramps can be absolutely debilitating. It can cause a whole slew of symptoms also because it could be due to muscle cramps from the uterus. It could also have a hormonal problem because the hormonal component can add things like nausea, vomiting to that whole situation because the hormonal influxes really screw with your body. It can cause hypovolemia because of the pain, the stimulation of, or hypotension because of the stimulation of the vagus nerve, which is a kind of same area. Usually they say that it's women who are not sexually active or have not had children. This is unfortunately the solution for dysmenorrhea is the OBGYN just goes, well, just have a baby. Well, maybe I don't want a baby. So this can be debilitating. You will see younger girls who are not, yes, a UTI can cause PID if it transfers. Everything's very close together down there. This is also, they tell you to wipe from front to back, because usually any of the bacteria that's in the vagina you don't want to bring forward into the urethra because you're just going to make things worse, and you'd have to like really get it up there. But this is UTI's problem. So you might see dysmenorrhea in younger girls who are kind of just learning what their period is and learning to deal with the pain. And dysmenorrhea is actually one of the reasons that women have an extended period of getting medical care for things, because women are used to kind of having pain once a month for about a couple days. So if they have pain, they're like, well, is this real pain or is not like normal pain that I should be dealing with, or is this not? So just things to keep in mind. Little schmerz, my favorite. Usually the pain from ovulation. There you go. It's usually unilateral. Mid-cycle pain lasts about a day, anywhere from 1 to 3 days. If this is that mature follicle bursting, and a little bit of blood and fluid being released into that abdominal region that's causing discomfort. Usually resolves on its own, and it's not a big deal. However, remember we talked about this already. If one of those ovum follicles bursts and then recloses, it can form what's called a follicular cyst. Of that cyst can then fill with significant amounts of fluid, and can either drag that whole ovary down, and cause a torsion, or it can rupture and be extremely painful. Now, any unilateral pain in a female should be taken extremely serious regardless. That's a hospital trip you need to go get, checked. The problem with the torsion is it can kill, like just like in a man when a testicle gets has experienced torsion, an ovary experiencing torsion can also become ischemic and then die. So now you not only have the risk of hemorrhage, you have the risk of infection and necrosis secondary to that ischemic ovary. And if those cysts do burst, you're usually seen in like younger females who are very athletic, right? Maybe they bounce it around. It can be, again, debilitating pain. So ovarian torsion. So the ovary is, if you look at this picture here, has this ligament that kind of secures it to the uterus, and it also has like these this membrane, right, that kind of holds it up onto the fallopian tube. So all of the blood supply that's coming through can get cut off. This can be caused by a cyst. This can be caused by PID or any sort of other adhesion. Women who deal with endometriosis can be at increased risk of ovarian torsion. There was a really interesting article in, I believe, the New Yorker that spoke about, a man wrote it, about his wife's experience in the ER and how they didn't take her pain seriously. She was having significant unilateral pain. It was very, very, like, it was debilitating. She was screaming in pain, and they put her in the ER for hours. Gave her some pain meds and told her it was all in her head. And by the time they finally got to her, her ovary had fully necrosed, and she ended up losing the ovary. So any female who you believe is experiencing significant pain like this, you need to make sure that you advocate for them. I've had one girl who was 14, and she had a history of ovarian cysts as well as ovarian torsion. And I pretty much walked in with like, she's a surgical emergency until proven otherwise. Like, she has a history of an ovarian torsion. She's in the same pain as she was the last time she had it. Like, she needs an ultrasound, like, stat. Because if you bring a man in with testicular torsion, he at least has some external signs because that testicle might be like red and inflamed. And all of a sudden we take that very seriously. We want to save the testicle, but if it's your ovary, we can't see it. We don't worry about it all that much. Cystitis or a UTI, very, very common. Most women will have a UTI at one point or another in their lifetime because, again, it's very moist down there, and that moisture breeds bacteria. And if a woman is not careful with her reproductive hygiene, it can just spread very easily. Those bacteria grow legs and they start wandering upwards, okay? Especially in older women, those UTIs are very, very dangerous, okay? They turn into sepsis very frequently, okay? And not all UTIs will have that frequency of urination or burn or smelly urine, okay? Sometimes it gets up and goes high up into the kidney right away, and that bladder infection goes right to the kidneys. So it's always a good idea to have UTI on your mind, especially when dealing with older women, okay? It's very, very common due to that little teeny tiny urethra and that exposure right in that very moist location. Endometriosis is considered a inflammation of the uterine lining. While they say it's usually due to infection, this is also one of those things that just happens. Endometriosis doesn't have a great they don't have a great idea, like, knowledge of what causes it, and they also don't have a great knowledge of how to, like, diagnose it. Women who have endometriosis will be in terrible pain for years before they actually get a diagnosis and or some sort of resolution. A lot of these women end up requiring surgery because the endometrium, which is usually inside the uterus, will often go and travel. Okay, so it might end up anywhere within the abdominal cavity, and that causes adhesions. Okay, so that tissue, that foreign tissue that's not supposed to be there, will start to, hold on one second, my boss is calling. not true because they're thinking their things a little. There we go. Yeah, actually, so. Okay. All right, sorry about that. Amount of time orbiting to, I believe it's about 6 hours. Just like any other tissue, right? Time is brain. So if it's good for a brain, it's good for an ovary. It's probably got a little bit of an extended time, um, just based on the fact that brain is a little more sensitive than other tissues. But I would say probably about 6 hours is a good window. To kind of keep in mind. So endometriosis, right? It causes these adhesions because these patches of endometrium that gets out and about throughout the abdominal cavity starts to glue the organs together, and those adhesions are very painful because you can't get that proper motion, right? There's a lot of moving that goes on in your body as you like kind of go through normal activity. So there's people who've had to have, laparoscopic exploratory abdominal surgery to remove those adhesions just so they can have a normal life. Um, and happens to relatively young women also. So it's not necessarily due to childbirth or an abortion. It can happen absolutely any time. It's just like a dysfunction of the endometrium. Um, Usually the symptoms are worse during and like the menstrual cycle, right, with the hormone fluctuation. So like if you're having menstrual pain, that menstrual pain can be anywhere else that the fallopian or the not the fallopian, the endometrium is getting signals from the body to contract. Okay, so it could be or it needs to be released, right? So it's getting that hormonal not all the information, but it's not able to escape from the body. Um, so again, we talked about this. Usually, there's a lot of pain. And again, it's cute to me how they're saying, oh, it's more common in women who defer pregnancy. You can be in your teenage years and end up with endometriosis. Um, that's to me is the patriarchal oversight of trying to get women to get pregnant young, uh, better and less threatened. Ectopic pregnancy. So an ectopic pregnancy is pregnancy anywhere outside of the uterus. Okay, that could be almost anywhere. Okay, including remember the fimbriae. They do this if they kind of miss and the sperm get all the way down there. That that egg can be fertilized abdominally, okay? And it can kind of latch on somewhere and start trying to grow. Usually around 2 months of pregnancy is when it will outgrow a fallopian tube, okay? And if that fallopian tube ruptures, severe symptoms, internal hemorrhage, sepsis, shock, okay? It's dangerous. Again, this is why we take any female of childbearing age, her lower abdominal pain, especially unilateral pain, we take it very seriously, okay? Because it could be a legitimate surgical emergency due to pregnancy, and she might not know she's pregnant. Her, and her symptoms might be kind of vague. So you want to make sure that we take that seriously. Always believe a woman and her pain. Vaginal bleeding. All right, we talked about this. Vaginal bleeding can be other non-menstrual bleeding. The most concerning, in my opinion, is when you have a postmenopausal woman who is having vaginal bleeding. Most of the time, this is not a good sign. This is usually a sign of cancer or some other an adhesion, potentially with intestines, where there's a loss of blood. Okay, because it's a path of least resistance. There's no real musculature that's really preventing it at that point. If a woman is in fact pregnant while she's having vaginal bleeding, it's most of the time either related to a spontaneous abortion, or it's some sort of disorder of the placenta, like the placenta previa, right? So if that placenta is across its cervical opening and the baby kind of punches the placenta a little bit while it's moving around, there's your problem. And also, it could be, if she's extremely pregnant, the onset of labor. And there is no one you do not live nor die in my ambulance, okay? We don't create new life. We wait till we get to the hospital, hopefully. Most of the time, if there are significant clots, this means that the bleeding is at a rate greater than the menstrual flow. It also could just mean that the previous period was not as effective as it should have been. It did not fully clear the uterus. There's also dysfunctional uterine bleeding, right? There's a lot of things involving bleeding in the gynecological realm. This could involve irregular periods, okay? So there are some women who just have irregular periods, right? It might be shorter than 28 days or longer than 35. If a woman goes from having a very regular period to having extremely irregular periods, that's a problem, okay? That's usually a hormonal issue, or there's a potential possibility of pregnancy. Heavier than normal bleeding, we talked about that already. Any bleeding that lasts more than 7 days. If you have a woman who is bleeding for more than 7 days, I would highly recommend you ask her about her birth control preferences. Depo-Provera, which is the injectable progesterone shot, especially if it's one of the first times the shot has been given, it creates a 3-month reservoir of progesterone in whichever muscle it is injected into, but it can cause dysfunctional uterine bleeding, okay? The body's like, what is this new stuff? And there's just like constant light bleeding for an extended period of time. The bigger problem is when bleeding lasts more than 7 days and it's heavy bleeding. I watched an FDNY crew bring a lady in who had just had a DNC. A DNC is a dilation and couturage, which is the most French sounding word for we scrape the inside of your uterus to get all the stuff out because something happened. It could have been an abortion or a spontaneous abortion. It could have been almost any number of different things, but it's a surgical procedure where they go in and they more or less they scrape the inside of the uterus to make sure that everything is out. And she had been bleeding for 2 weeks heavily. Her blood pressure was 70/30, and they had sat her in a wheelchair because she couldn't walk into the ER and they couldn't be bothered to put her on the stretcher. That is a problem, okay? Don't be that asshole, please. For the love of God, don't be that asshole. Actually take care of your patient. Yep, 100%. Women can have their period long. Again, so menopause can be delayed to a number of different reasons. If she started her menstrual cycle late in life, that 63-year-old woman could be still having periods because, hey, maybe she didn't get her first period until she was 18, right? Or maybe she was on birth control for an extended period of time. Birth control, you're not, hormonal birth control prevents you from actually releasing an egg. So those eggs still potentially want to be released. So you're going to have an extended menstrual cycle and delay menopause, which in the grand scheme of things is probably healthier for her cardiac health. So it happens. So any sort of dysfunctional uterine bleeding, you should please take it seriously. This one creeps me out. The uterine prolapse. This is when the uterus falls down into the vagina. This is potentially due to, most of the time, traumatic childbirth or the birth of a very large child. This is why we don't pull on the umbilical cord to deliver the placenta, because you might bring the uterus with it. Okay, there's a number of different things that could cause this, but it just folds in on itself and tries to escape. There's a feeling of like she's quote unquote sitting on a small ball. There's different grades of a uterine prolapse. I like how it looks like it's flying. This uterus is flying. It's got like little wings. So usually the uterus kind of hangs out, as I said, in this more almost a horizontal diagonal kind of position. It starts to go down, but the problem is as it goes down, the vagina starts to work as like a noose on. So it kind of squeezes, and when it squeezes, it starts to cause ischemia because the blood return can't get out. So it starts to become swollen, which means it's harder to get back in place. We do not deal with uterine prolapse. If there is anything actually protruding into the external environment, we treat it much like we would an evisceration. Moist dressings, cover it to keep it sterile, and go to the damn hospital as quickly as possible. Foreign body obstruction. Things happen. People do shit that they shouldn't do. So again, go to the hospital. Oh, here's toxic shock syndrome. Okay, Staphylococcus. Okay, Staphylococcus is a absolutely wild bacteria that can do a lot of things because it produces a lot of toxins. Okay, so as I said before, right, you will have the sloughing of the skin on the palms and the feet. There would potentially be a rash, high fever, vomiting, what's called like a sunburn-like rash. Okay, altered mental status, any of these things. If you look on the bottom left there, that's a picture. So the an extended the tampon left in for an extended period of time is usually the cause of toxic shock syndrome, and there's definitely a risk of having fingers and toes amputated because of the sloughing and the necrosis and gangrene that ends up happening because of the staph infection. Okay, so always keep that in mind as a possibility, especially for women who don't know how to use tampons or aren't taught how to use tampons.
Nicole, how long does it have to be for that gangrene to develop?
It completely depends on the person. It depends on the bacterial load and the amount of toxins are being produced. It can happen anywhere from like 3 days to 7 days or longer, depending. It depends on how sick and the previous level of health, like how healthy the patient was before, they started getting this horrendous infection. So some good questions that you should ask during a gynecological assessment. Right, obvious or gynecological patient assessment. Much like everything else, right? Fever, syncope, diarrhea, any of these, abdominal cramping, any of these things. Okay, because usually that kind of leads you down one pathway. But then you should also add other things on top of it. For example, how many times has the woman been pregnant, if at all? Is there any possibility of pregnancy, right? Has she had a missed period, a late period, breast tenderness, morning sickness, urinary frequency, which could be indicative of a UTI as well. Any recent unprotected sexual encounters, okay? Again, there's a lot of people who don't understand how their body works and are like, no, I'm good. I am in the safe zone, and they're not in the safe zone. And then they are unwanted pregnancy. C-sections can indicate high-risk pregnancies, depending. That's not always the case. I think they're trying to move OBGYNs away from just doing optional C-sections, because the problem is or subsequent pregnancies are increased risk because now you have a muscle that has been cut open, and muscles do not heal 100% ever. That's just not how they do. They end up kind of being weak in the spot where they were, injured, including, I don't know, a giant cut. They are pushing for the vaginal birth after C-section, which is VBAC, but that's not always practical for every woman. Uterine rupture is always a possibility. I do believe you go over that in obstetrics. So, general good questions you should be asking. Last menstrual period. There's some women who really don't know, don't keep track. I have an app on my phone. I have no idea. I couldn't tell you. I have to look it up. Just good things to know about history. Any previously diagnosed OBGYN problems, right? Do they have a regular period? Do they have they had a DNC or an ectopic pregnancy? Do they have a uterus? Okay, I know a few younger women who had such bad endometriosis that they've actually had a hysterectomy. Okay, and if they've had a hysterectomy, was it total or did they leave the ovaries? Okay, there's a lot of different ways that they do these surgeries now. Any sort of vaginal discharge, blood versus purulence, type, if there's a contraceptive being used, right? IUDs are inserted into the uterus. They may become dislodged. There is another contraceptive called the Assure, which is like these weird little springs that they were putting inside of the fallopian tubes to cause scarring, to essentially to tie one's tubes. But the concern with that was that the Assure springs were not staying where they were, and they've ended up in people's hearts. There was a huge issue with those. There are other types of contraceptive. You have patches. You've got the pill, which pill plus smoking and or for sitting long periods of time can increase your risk of blood clots, right? Those hormones can increase your risk of, in combination with smoking, increases the risk of blood clots. There's there's a 3-year hormonal implant. It's like a little bar that can be inserted into the arm. There's a lot of different things that are out there. So contraceptive types could make a difference. Then you have, right, if she's under any emotional distress, right? Well, yeah, let's talk about that, but at the same time, let's not make that the focus. You want to make sure that there's nothing actually medical going on with her before you it's all in your head. For the most part, a lot of your physical exam is going to be kind of produced through questioning. Remember, the only time you look at a vagina is to confirm or deny crowning. So if she's not pregnant, you're not looking. You would like to give the abdomen a nice palpation to make sure that there's no rebound tenderness or guarding, rigidity, anything like that. Again, please don't pack a vagina. Unfortunately, sexual assault is a real thing that needs to be considered. About 80% of women do experience some level of sexual assault in their lifetime, which could be something as simple as being over the clothes groped or as awful as being raped. So be emotionally mature when dealing with these situations. These are women who need to go to safe centers, okay? So know which ones your safe centers are. Out in Suffolk, it's Stony Brook. I believe Good Sam is also a safe center, or sane center, depending. NUMC is. Out in Queens, it's Queens General is a sane center, okay? So a lot of women aren't going to necessarily want to talk about this. It's embarrassing. There's an awful culture of victim shaming in this country where, well, what were you doing? Why did you bring this upon yourself? Where really it's about, men not respecting boundaries or being goddamn grown-ups. Sexual assault is not always very simple and straightforward. It can be a very physically traumatic incident in so much as there's some sort of actual abuse, hitting, punching, biting, bone injuries that couldn't be associated with an attack. You still want to make sure that you're assessing and treating any life threats that are apparent, and only ask questions that are pertinent to treating the patient's physical injuries. You are not a cop, okay? You are not going to be asking her if she knew who her attacker was or if she could describe him. That's somebody else's job. You are going to ask if she has any injuries that she needs treating, that, she doesn't need, necessarily show you if she doesn't feel comfortable, as long as it's not going to kill her. She should not be changing her clothes. She should not be showering or washing her hands. All of that is becomes evidence. Make sure that any statement that the patient does make, you thoroughly and accurately document it, okay? Because this is going potentially to court. Again, these are all BLS things, right? If you have to take the clothing off, don't handle it as that much. It needs to go into a paper bag. If there is a crime scene, preserve it just like any other crime scene. But you need to make sure that you're providing that patient with a safe environment. You are not judgmental. You are not making inappropriate remarks. You are worried about that patient and her well-being, period, end of story. And that patient might not be the friendliest patient at that time because people respond to trauma in different ways. So she might not be, crying or, what you would, expect. She might be angry, or defiant. So you need to make sure that you're patient. All right. Questions, thoughts, concerns?
Yeah, I have a question.
Yeah.
Is it possible, so you said twins, that happens when both of the fallopian tubes produce a egg at the same time, right?
Both the ovaries, it can happen in a number of ways. So either there's two eggs that are released, which most of the time if that happens, it's both ovaries are participating, and then both eggs are fertilized. Or it's one egg that's fertilized that then splits into two.
Oh
Okay.
yeah. Is it possible for you to have two ectopic pregnancies, like two fertilized eggs inside the fallopian tubes?
Oh, I'm sure.
Yeah.
It's also possible for you to be pregnant with twins that were fertilized at different times, and they're not real twins. So if you have one ovary that releases an egg that then gets fertilized, and then in the early stages of pregnancy, the other ovary then also releases an egg, and then you have either the same sexual or the next sexual encounter, that egg can also become fertilized. So you would have potentially two different babies with different gestational ages that would then be considered twins because they were born at the same time.
Okay. All right. Wow. That's crazy.
Nicole,
Yes.
I'm just looking at the syllabus, and this doesn't seem to be on the next test, according to the syllabus.
Today's the 27th.
Yeah, today is the 27th. The 27th says infectious disease, communicable disease, abdominal and gastrointestinal disorders.
Glad that mine's up to date.
I could be wrong.
No, you're right. I'm just saying my syllabus
Isn't up to date.
says that that's September 13th.
Wait, did you say September 13th?
Yeah, that infectious diseases, communicable diseases, abdominal and GI is on mine as September 13th. So let's all time travel. We didn't do that already, right? Now we just did respiratory, neuro, endocrine.
Right. That was our last test. Respiratory, neuroendocrine, and immune.
You got gynecological out of the way. I have a headache.
Sorry.
It's all right. We did hematological though, didn't we? I feel like we did hematological last week. Hold on.
No.
No, we did immune last week. Immunity.
All right, cool. Let's do hematology. Forget musculoskeletal.
Looks like
hematology.
gynecological and hematologic are exam 10 on the test after the next one.
Yeah.
Yeah, I think this one, it looks like it's infectious disease, communicable disease, abdominal, gastrointestinal, genitourinary, and renal. And hematologic. I don't know why hematologic is twice, but it is actually twice.
It is twice. No, I actually picked that one up. So, all right. So then let's do infectious diseases and abdominal, and then we'll just whatever. I'm not doing G. No, for the love of God, I'm not doing GI again or GYN again, ever again. Done. You've learned it. You've learned it. All right, cool. So let's do abdominal. It's like a pretty quick one. Learning.
This whole
Are you
lecture
gonna
is
make it a
basically
separate
notes.
recording?
No, because I'm not sure how to do that on WebEx. Just know that, hold on. You have an hour of GYN before on this one. All right, here's abdominal. So in the grand scheme of things, abdominal emergencies are not really any different from BLS because the abdomen is a mysterious location where we don't have a good way to actually assess it in the field because we don't have ultrasound. We don't get to play with that here in this region. But your gastrointestinal system is kind of how you fuel it. It's the gas tank for your body, right? So it starts with your mouth and ends with your anus. It provides you with water, electrolytes, nutrients, right? Your 3 macronutrients, carbohydrates, proteins, and fats, okay? They're all essential for living. From the mouth, whatever you consume goes through your esophagus. It goes through a sphincter into your stomach because that sphincter is important from keeping stuff from regurgitating up your esophagus. Where it gets digested in your stomach. Your stomach has a pH of approximately 1. Okay, it is highly, highly acidic. After that, it moves in from your stomach. Your food or whatever is being digested is now called chyme or chyme, CHYME, and moves into your duodenum. Okay, that's your first about 10 inches of your small intestine. At this point, this is where bile salts are secreted from your gallbladder. Okay, your pancreas helps participate in the bile salt production, and it's then stored in your gallbladder and then secreted into your duodenum. Bile salts help reduce the acidity, okay, and keep your system from burning itself from the inside, okay, because your stomach is good to handle that level of acid. The rest of your system, not so much. So after that acidity is neutralized, this is also where the majority of your absorption happens, okay, for nutrients and water. From there, those nutrients that are absorbed go right to your liver, okay, through the portal vein. And through the portal vein, your everything starts getting broken down into smaller components that have not already been broken down by your stomach and transported throughout the rest of the body for storage. Or if it's glucagon, gets stored in your liver as glycogen if it's not being used. Okay. You have about 26 feet of intestines, so that's about enough to make a nice hammock. Persistent abdominal pain that lasts for several hours or more should be a good indicator that there's some sort of other underlying condition, okay? usually your abdomen is very good at resolving issues, right? Food poisoning, right? Few hours. Your body's like, get it out right now, right? Peristalsis is pretty incredible. It is that muscle contraction pulsation that moves stuff along. So if there's something kind of like low key that's an issue, it'll deal with it relatively quickly. So remember back in the day in BLS, excuse me, where we did quadrants? Well, now you're ALS, so now there's 9 spots. You have the tic-tac-toe board of your abdomen. Okay, the ones that are really primarily the ones that you see in emergencies, like bad emergencies, upper right, okay, where you will have patients who are having gallstone pain, gallbladder attacks, okay. The bottom right, which is usually appendicitis, okay. Bilateral lower abdominal, right, in women, okay, that's your possibility of ectopic. And then your epigastric region, okay? The epigastric region is that center top where that might be indicative of a patient having a cardiac event, okay? Lower center bladder infection, right? You might have a patient who has pain there that is UTI or menstrual cramp related, okay? Usually the upper left would be the spleen or any spleen pain, but that pain's usually referred up into the left shoulder. Gallstones also, that pain's usually referred up into the upper right. Questions that are really good, right? Do you have a history of you know, GI issues, right? You might have patients who have Crohn's disease or have a feeding tube or, you know, an NG tube. Maybe they've had a change in bowel habits. Okay, this is especially significant in like the very young and the very old, right? If a very old person is extremely constipated, they can have cardiac changes due to their constipation, right? As that vagal nerve gets stimulated. That's the word I was looking for. Okay, so your abdomen is like this kind of vast expanse of possible issues that we aren't really going to potentially have a great answer for. These are patients who need to go to the hospital and have a more thorough exam than we can do. If you are assessing an abdomen, please, for the love of God, if the patient's having pain, that is the last place that you palpate. Okay, because if you palpate it, you're going to spread that pain across the entire abdomen and the rest of your assessment is worthless. So there's 2 different kinds of pain. The first type is visceral pain. Visceral pain is that crampy pain that's commonly caused by distension or stretching of hollow organs or ligaments, okay? So this is that kind of pain you get when you are about to have some really horrible diarrhea, okay? That's visceral pain. It's kind of considered colicky, okay? Crampy, generally kind of uncomfortable. Most of the time you see this kind of pain in various itises, right? Your appendicitis, cholecystitis, intestinal obstruction, right? A patient can have an intestinal obstruction and their body's trying really hard. No, it's not because it's acidic. That's just the way that the pain receptors interpret stretching is through cramping. That's visceral pain. And then you have somatic pain. Somatic pain is usually like a pinpoint kind of pain. It's constant and localized. So if you have a patient who has had like is having sharp and stabbing pain, it could be because they've got something that's ruptured, especially in the abdomen. And you're taking the appendix into account. The patient might have what's called a reactive abdomen. A reactive abdomen is when that patient is experiencing a significant amount of pain that is not consistent with what you've done. So if you hit you can't see. If you hit the stretcher the patient's laying on and they're screeching in pain, that's considered a reactive abdomen. Something has most likely ruptured or is about to, and they need surgery. Period. End of story. I've had one of these in my career so far, and she bypassed the ER, went right up to surgery. Okay, it was very. It's either usually appendix, a gallbladder, could be an ovary, like an ovarian torsion that has now burst because sometimes that ischemic organ can become very bursty. Some sort of intestinal rupture, okay? Most of the time, you'll see this with an appendix, okay? And then you have referred pain, right? You have pain in one spot that is then being sent somewhere else. This is what you usually see with your gallbladder and your spleen. So the spleen's upper left quadrant. If you have a patient who has a splenic injury, a laceration or bruising or something else, usually due to trauma, that pain is usually referred up into the left shoulder. I believe that's Kehr's sign, K-E-H-R-S. Patient who has gallbladder or issues, it could be a gallstone, it could be cholecystitis, right? Just an inflammation of the gallstone. That pain is usually referred up into the right shoulder. If you have a patient who has appendicitis, that pain could be referred up into the umbilical region, okay? So that intense stimulation of the nerve endings can spread the pain other places. If you remember the somatotomes that we talked about, right? When you have a patient who has like a spinal injury and they have like different levels of sensation, it's kind of the same nerve tracts that are involved. And you can see how that pain will travel. There you go. Other areas for referred pain. Okay. Right in the back, right? Between the shoulder blades, right? It could be the heart, stomach. Just different locations. Here's a fun mnemonic for acute abdominal pain. There's two. Bad gut pains, which they come up with this shit. Or ectopic, right? So ectopic pregnancy, endometriosis, cystic diseases, cystic being your bladder, or rupture, torsion of the ovary or the testicles. Testicle can also have referred to a torsion of the testicles can also refer pain elsewhere. Ovulation, right? This is the more female one. Incomplete abortion. Cystitis gets 2. Yeah, our mnemonic only kind of worked. Other possibilities for gender-neutral abdominal pain, right? Could be appendicitis, diverticulitis, bowel obstruction, gastroenteritis, right? So inflammation of the stomach, gallbladder problems, urinary tract infections, toxins, pneumonia, right? Because pneumonia can also present with abdominal pain. I've seen that patient having a little shortness of breath, maybe has a cough, but they're really complaining of nausea and vomiting. It happens, okay? Especially in the elderly, their pain and their symptoms start to get very vague. Inflammatory bowel disease, Crohn's, all of these things, right, are possibility. There's a very wide span of potential pain, but what you're most concerned about is making sure that patient is comfortable and their blood pressure is sustainable for life, okay? Do a full workup. If a patient has abdominal pain, there's nothing stopping you from doing a 3 and a 12 and a finger stick, okay? Do it, because it could be referred pain from somewhere else in the body. It could be any number of things. So just, it's good practice. Don't be lazy. Anorexia in this realm is when a patient has lost their appetite. It's not just necessarily the psychological disease. So you might have nausea, vomiting, anorexia, right? The patient might have some sort of stomach issue, or pancreatitis, intestinal obstructions. Diarrhea could be due to inflammatory or infectious processes, right? Food poisoning can do that. Constipation, right? A patient might be dehydrated, or if their patient's on narcotic pain medications, constipation is very possible. Any changes in stool color, right? So if you have patients who have like have gone from having normal bowel movements to having a very light or clay colored bowel movements, that's usually a sign of a biliary tract obstruction, because your bile gives your feces that distinct brownish color. It also, right, you want to make sure that you're checking for intestinal bleeding, right? Is it dark, sticky stool? Is there any bright red blood? Chills and fever, right? Chills and fever, a good sign of infection somewhere in the body. Could be a number of places inside of the abdomen that's possible. Patient with abdominal pain or that peritoneal irritation tend to like to be in a fetal position, because when you bend your knees and bring your knees up to your chest, it actually will release the tension on your abdominal muscles, which then causes relaxation and a relief of pain, because when those muscles are stretched, it's pushing against the peritoneal membranes. Bruising, ascites, distension, all of these things you should be assessing for That means you actually have to look at your patient, okay? Always palpate gently. If there's any sort of rigidity or spasm, you should be able to detect it. It might be hard. Sometimes patients aren't going to have that rigidity right away. Usually rigidity is a level of irritation. It could be caused by blood. It could be caused by a ruptured organ. Lots of different possibilities. Most of the time when it comes to patients with abdominal complaints, our main role is to provide supportive care. Okay, so if they are in pain, pain management. If they are hypotensive, maybe some hypotension or some fluid support. Okay, if they're vomiting, Zofran, right? We have great options for some of these kind of vague complaints. GI bleeding should be taken very seriously because for the most part, the first GI bleed that a patient has is the most serious because it tends to go overlooked for a period of time. But you can lose a crap load of blood inside your GI tract and not even notice it. So these patients could be potentially very unstable. Oh, hey, things I just talked about. You might have a patient who has a long, slow bleed, and these patients might present with fatigue, shortness of breath, kind of generalized weakness. So, there's a lot of different possibilities here. Upper GI bleed, right? If it has made it into just the stomach, that blood will look like coffee ground because it's been digested. If it makes it through without being vomited back up, it could look like it's called melena, right? That's dark, sticky stool. Patients might have just kind of non-specific bleeds where you know that they're not feeling well. They're talking about that, again, that dizziness and whatnot, weakness. Or they could have hematochezia, which is that bright red blood. Is usually indicative of lower GI bleed. It could be something as simple as hemorrhoids. It could be something as complicated as like cancer. Hold on one sec. I love you. I'll play back. All right. Yeah, that pretty much sums that up. So there's a number of different things that can cause GI bleeding. Ulcers are one of them. Variceal ruptures are very popular in patients who are alcoholics or have other sorts of liver disease. It could be hepatitis. Mallory-Weiss syndrome is usually caused by or seen in pregnant women who have bad morning sickness or hyperemesis of pregnancy because it's tears caused by the ruptures of it's caused ruptures within the esophagus, tumor cancers, IBD, Crohn's disease. Any of these things can cause a number of different issues. Ulcers are usually caused, the number one cause of peptic ulcers is H. pylori, which is a bacteria. Excessive NSAID use is also possible. And then there's people who just have like weird unspecified issues. Alcohol is bad for your stomach, causes a lot of erosions. What else? Lower GI, right? This is where you see your diverticulitis, colon cancer, different inflammatory bowel diseases. The difference between, I will talk about this in a little bit, ulcerative colitis and Crohn's disease is Crohn's disease can happen anywhere along the GI tract, so it could also be a cause of upper GI bleeding. Diverticulitis, which is seen in older groups. And this is sort of when you'll see patients who have a change in their bowel habits. We talked about this already, right? Most of the time you have patients who you're just kind of going to do supportive care, oxygen, some fluids. You don't want to necessarily, patients who are having bad GI bleeds, you don't want to crank their blood pressure up very high, right? Because that's when you start to dislodge any potential clotting that you've done and you make the bleeding worse. And then you won't know that you've made the bleeding worse. So permissive hypotension is definitely a spot that you might want to consider in this realm. If you happen to have the ability to do end tidal assessment, if you're doing a blow-by, or if your patient is intubated, because GI bleeds can lose consciousness very quickly, might need airway control, or you might need airway control if they're vomiting up copious amounts of blood. Anybody who has a N tidal of less than 25 is usually a sign of very poor perfusion. They need blood pressure support, okay? Blood pressure support is one of the better ways to manage most patients. You need those blood pressures. Acute gastroenteritis, aka food poisoning, okay? I'm sure everyone has dealt with this at one point or another. This is inflammation of the stomach and intestines, most of the time brought to you by your signs and symptoms are going to be abdominal cramping, nausea, vomiting, diarrhea, anything that Pepto-Bismol might treat, okay? Number of different ways. Most of the time you've eaten something off. That could be that you have given yourself something through the fecal oral route by accident if you're in a restaurant that doesn't have good hand hygiene. It could be person to person, could be contaminated water, especially if you're like in a location that doesn't have like potable drinking water, or you're hiking and decide you're going to drink from a stream or something. There is a number of different bacteria that might participate in this discomfort, okay? Most of the time, this is relatively self-limiting. It resolves 24 to 48 hours. Patients who are lactose intolerant will have potentially longer symptoms because a lot of them, if they know they're lactose intolerant and they continue to eat dairy anyway, are doing it to themselves. Chronic gastroenteritis is that long-term issues in the gastrointestinal tract. Again, similar as the acute, but it doesn't go away. This very similar: nausea, vomiting, fever, difficult loss of eating. Could be due to a virus. It could be due to a parasite. It could be due to alcohol or aspirin use. Okay. Longer stomach flu, less than fun. So there are two different types of inflammatory bowel disease. We talked about this a little bit already. So chronic, you have Crohn's disease, which is like these patchy areas of disease within the bowel, which can cause all sorts of different problems, such as like narrowing, which is called strictures. So people have issues with constipation or being able to actually have a bowel movement. It can occur anywhere throughout the system, cause bleeding, and it can happen earlier. Both of these are considered autoimmune diseases, so these patients might be on immunosuppressant medications to kind of reduce their flare-ups. Ulcerative colitis is usually just the large bowel becomes inflamed. These are patients who you might see who have a colostomy bag. Okay, you'd be like, you're so young. I'm like, yeah, no, their Crohn's disease or ulcerative colitis was so bad that they were bleeding regularly. They couldn't eat, they couldn't digest. They were, dealing with a lot of other issues. They might have had, parts of their bowel resected or removed to improve their quality of life. So ulcerative colitis usually coincides with with fatigue and weight loss and anorexia, a lot of bleeding, plus, right, because it's inflamed and potentially infected. Lots of diarrhea associated with it. Crohn's disease, any part, more autoimmune than considered to be more autoimmune than ulcerative colitis. Lots of different concerns. The intestines might adhere to one another and then cause fistulas causing weird connection between intestines. If it's not under control, it can cause a lot of severe issues for patients. So diverticulum are these little sacs or pouches that kind of develop within the wall of the colon, right? So your colon has these like little fingers, because these little fingers are increasing the surface area so that in the colon and the intestines, so that you can absorb more water or nutrients. As you get older, the little things kind of get stuck in between those little fingers. Most of the time it's small stuff like nuts and seeds. Okay, and as they kind of live there in your intestines, they create these little outcroppings, and those outcroppings are called diverticulum. The possibility of those becoming obstructed with fecal matter or infected is usually what causes a diverticulitis like episode, okay? Patient might have cramping, discomfort, some diarrhea, or they might have some like bright red issue, like bleeding. The problem is if one of those little outcroppings becomes like severely infected and becomes an abscess, which could rupture and cause peritoneal irritation throughout. This traditionally does not happen in younger patients, okay? And people under less than 30, not really, it's not a thing. You usually see this in your older population. So your appendix is approximately the size of the last piece of your pinky, okay? So if you look at the appendix chilling up here on the screen, get my doodle. That's the appendix in this picture. That's a little bit bigger than the last tip of your pinky. All right, it should be about that big. They are not 100% sure still what the appendix does. It was thought that it helped process raw meat back in the day, but they are really not sure. It could become infected because there's like a lot of bacteria that live in your gut biome. Okay, gut biome actually is really good in terms of helping you digest things that you and breaking stuff down into nutrients that you otherwise wouldn't be able to make, like vitamin D. If the appendix also becomes blocked by like a echolith, which is basically a poop rock, it can become extremely infected. If it ruptures, it's very, very bad. Most of the time, you would expect to see a patient complaining of unilateral right abdominal pain, usually somewhere in between the umbilical and the iliac crest in that region. But patients can have completely vague atypical symptoms. They could just have nausea, vomiting. They could have global abdominal pain. So you want to make sure that you are asking good questions like, hey, do you still have an appendix? Okay, patient may or may not even have a fever with this. So it's called McBurney's point. So you have that iliac crest, that spine right there of your pelvis and your umbilical, right? It should be kind of in between. If you start poking in that area, they're not going to like you. A lot of abdominal pain and cramping. Again, you might have just some kind of vague, diffuse pain and symptoms. Peptic ulcer disease, okay, usually it's caused by too much the bad combination between gastric secretions of acid, the enzymes, pepsin, and the mucosal barrier. Most of the time, if a patient has peptic ulcer disease, they will be most uncomfortable on an empty stomach. Okay, they will be less uncomfortable after they've eaten, or if they've taken antacids, or if they've vomited. Okay, that's usually a test question. You have a patient who's complaining of burning, gnawing abdominal pain. They say it gets better after they eat. What do you suspect? An ulcer. Okay. Bowel obstructions. They can happen in a number of different ways. Young children, it usually happens through a process called intussusception, which is sort of like the intestine like slides into itself, and then it gets constricted. It could be an ileus, which is usually like that twisting right down here on the bottom that you see. It could be fecal impaction, okay, or volvus, or any other number of different issues where the intestine is not able to move things along. One of the things I've learned is that if your patient is still passing gas, they are not fully obstructed. A patient who can have diarrhea while still having a bowel obstruction. So basically what the body does is it starts to try to move that bowel obstruction along, and it starts to pull as much fluid into the intestines as possible, which then initiates diarrhea because it's trying to flush it out, but it doesn't necessarily mean that it's moving. Okay, it might be so hard and impacted that it's not going anywhere, or might be stuck because of an intussusception or any other number of anatomical problems. So as long as the patient is passing gas, they are not fully obstructed. Diarrhea is not a good indicator of a lack of bowel obstruction. This is this picture right here is a giant colon or something like that. So you see how that top piece of intestine is black, that's ischemic, that's necrotic, that can lead to sepsis. So this is why bowel obstructions are extremely important to have a high index of suspicion for. The problem with that also is as that piece of bowel becomes necrotic, it can burst. Okay, and then your patient's in really big trouble because they are going to need like an abdominal lavage to clean out all the potential infectious material because they'll go septic. One of the things that are usually, unfortunately, not on a lot of people's radars is the acute mesenteric ischemia. So we're familiar with pulmonary embolisms and we're familiar with heart attacks. What we're not really good at picking up is essentially the heart attack of the bowel. So the mesentery is this kind of netting that goes in between all of your intestines. It's made up of vasculature and ligaments and membranes that kind of hold those 26 feet of intestines in place and supply it with blood. If something blocks that blood flow, you can start having essentially like a heart attack to whatever organ or area of the intestine or mesentery that it supplies blood to. So the patient's going to have like kind of weird, unspecified, vague pain that is extremely bad, but they don't really necessarily have actual symptoms, right? Like you don't have anything like that specific where you're like, they don't have an appendix, they had a gallbladder removed, and you're like, okay, well, those two things are off the list, and they had a normal bowel movement, and all of a sudden they just had this, onset of intense abdominal pain that they can't necessarily localize. You should have an high index of suspicion for mesenteric ischemia, okay? Just on your list of possible differential diagnoses, because that's what it ends up looking like. The patient will have a very poor outcome because they will end up losing a large portion of their bowel if it goes untreated. And we're not the only ones who miss it. This gets missed in hospitals a lot also. They need to do like CAT scans and stuff to see if, where the blood flow is. This is one of those, it requires contrast dye for them to diagnose it more properly. So pancreatitis. Pancreatitis can be caused by a number of different things, but most of the time it is due to, most of the time acute pancreatitis is due to gallstones that get stuck. So your pancreas creates bile, or your liver and your liver produces bile, and then that gallbladder stores it. But if it's stored in there, it can get what's called muddy, and as it sits there and gets kind of thick and gunky, it can produce gallstones. If those gallstones get stuck in the bile duct, it backs up, and bile is a digestive enzyme, and the pancreas also has digestive enzymes. If those digestive enzymes cannot release, it starts to auto-digest itself and cause a lot of pain, okay? This is also very common in patients who have long-term alcohol use, okay? You have patients who have like upper right quadrant pain, nausea, vomiting, discomfort, usually associated with gallbladder pain. This is when you have a patient who has gallbladder cholecystitis. What they normally do is they make sure that those stones are not blocking the bile duct, because then the patient could have bigger issues with their pancreas. We talked about this already a little bit, but most of the time, esophageal varices are caused by patients who have alcohol issues, okay? Their cirrhotic liver doesn't process, sort of like in congestive heart failure where the blood backs up from whence it came. If the blood can't flow through a fatty cirrhotic liver well, it will back up through the portal vein, which then backs up into the stomach and all the way up the esophagus, okay? So as that blood starts to push backwards, it starts to dilate the blood vessels, and those blood vessels can very easily burst. Patients who have esophageal varices, if they have some sort of significant coughing or vomiting episode, they could rupture one of those varices and start vomiting up extreme amounts of bright red blood. If again, this is one of those things where we can't control the bleeding very well, so they may in fact die from that bleeding because it is, you know, hard to control. Yes, alcoholics. Hemorrhoids. Hemorrhoids are relatively common, not only during pregnancy, but for people who are older than 50. It's, again, you have swollen distended veins in and around the anus. Would kind of present with bright red blood during a bowel or immediately after a bowel movement. Very small amounts of blood, not a lot of blood, as opposed to like a lower GI bleed where you might see frank red blood that's really like flowing. This would be like, I see some blood on the toilet paper after I poo, and you're like, that's probably a hemorrhoid. So cholecystitis. Cholecystitis has a very strong family history component to it. So it's an inflammation of the gallbladder. Know your 4 Fs, which is female, 40, fertile, and fat. Okay. Most of the time, these women who are overweight and still within their childbearing years will have an increased risk of cholecystitis. White people, more common, and if there's a family history of gallbladder issues, it usually gets passed along. Again, we talked about this a little bit with pancreatitis. If a stone blocks the bile duct, it can cause all sorts of bigger issues. The pain is usually radiating from the right upper quadrant into the right shoulder. It's called Murphy's sign, right? So the left side is Kerr's sign with the spleen, right side is Murphy's sign. If you have the patient take a deep breath in and then you palpate right on that costal margin, as they breathe in, it brings the liver and the gallbladder down. And if you palpate and you kind of hit the gallbladder, they will have extreme pain if it's cholecystitis. This is one of those signs that you might help differentiate between if they're having epigastric pain associated with potentially a cardiac event, or if it's cholecystitis. Also, very much happens in women who are pregnant. Okay, everything kind of gets smushed. There you go, positive mercy sign. Acute hepatitis, any hepatitis infection is an inflammation of the liver. There are 3 different. There's Hep A, which is usually relatively self-resolved. Hep B and C are bloodborne and can cause severe liver disease. They just recently, a few years now, have found a cure for hepatitis C, which is exciting because a lot of people are probably living a lot better lives now. Most of the time, the patient is going to have kind of dull symptoms, maybe a slight fever, loss of appetite, nausea, vomiting, might have some right upper quadrant pain, jaundice and dark urine that's caused by the liver not being able to process bilirubin. That is pretty much dead red blood cells. That's part of what your liver does. Here's your different types of Hep. So you can only get Hep D if you have Hep B, I believe, and Hep E is very similar to Hep A. Hep B is one of the most potent viruses that you can potentially get. Okay, it is more potent than HIV. It can live in dry blood for up to 2 weeks. You should be kind of familiar with that from your operations portion of the course. Hemochromatosis. Genetic, body stores too much iron, causes some joint pain, accumulates that iron in usually liver, heart, and pancreas. If you see it, that's kind of cool. Haven't seen it. Because storing extra iron in the liver can cause all sorts of liver problems. Could also cause heart problems because of that storage as well. There you go. Any questions on GI? Everyone's still alive. Lost you all. Okay. Y'all see any infectious diseases? If it's not jaundice levels, it's elevated bilirubin levels, and that's very, very common in a newborn because they're now diverting their blood flow to their liver because they didn't need to do that during fetal circulation. So jaundice babies usually just get to go hang out under a UV light for a few days and are perfectly fine and healthy. It's when you become jaundiced older when you have actual liver problems. I feel like most of these concepts are pretty familiar at this point now that we've just lived through a pandemic and we're still living through a pandemic. An infectious disease is any illness caused by an organism, whereas a communicable disease is one that can be passed from person to person. Wear a mask. Wash your hands. Pretty much what you really need to know. So sometimes infectious diseases are dependent upon geography, and this is where public health starts to become a thing, right? So Ebola became this big thing a bunch of years ago because of travel. Travel has kind of really reduced the walls of geography because it's easy for someone with an infectious and communicable disease to pop onto a plane and then fly somewhere else. Okay. But usually there's things that are relatively specific. So Ebola was relatively specific to Western Africa, whereas malaria is going to be specific to tropical locations because it's a vector-borne mosquito-driven problem. Okay, but if those mosquitoes happen to jump on a plane and go somewhere else, then we can have a spread of that disease. So there's also genetic factors that make people more or less susceptible, right, to different diseases, different community diseases. Some people have and like natural immunity to things because they're exposed to it on the regular, whereas if it was brought over here, we wouldn't necessarily be as protected. Basically, every agency that you're a part of needs to have an exposure plan. This starts with having an infection control officer monitoring people for not only monitoring your staff, but monitoring the neighborhood that one works in for different, influxes and things. Really want to go crazy. This is sort of where the whole COVID thing kind of fell apart because our health maintenance and surveillance really kind of failed. If you look at it critically, could have potentially been, protected if there was more quarantining earlier on, and by earlier on I mean like in China when it started. Disinfection and PPE, right? All of those things are essential. Wash your damn hands. 2 minutes. Twinkle, twinkle, little star times 2. Make sure that you're proactive in making sure that you are clean. Don't go putting stuff in your mouth. Don't eat and drink in inappropriate areas. Chapstick can be dangerous. Hand lotion can be dangerous if you are, not cautious with when and where you apply. Hospital rooms generally have different signs, so you should be, depending on where you work, you might see some of these things. Depends on what kind of precautions are necessary, right? So droplet precautions, right, for patients who are like, I don't know, tuberculosis. Whereas we have airborne, right, for COVID, where you're protecting your mouth and nose. Contact precautions up in the top left, right? That might be if someone has C. diff or scabies or something like that. So all different reasons why you might be protecting yourself because, hey, let's protect ourselves. Different types of way to decontaminate things from germs. So first we have sterilization. This kills everything. This is most of the time heat and pressure, okay? Autoclaves, right? This is what they use for surgical materials. And then you have high level disinfection, which is like, okay, we did a really good job. We didn't boil it, but we used like hardcore chemicals, anything that might have contact with mucous membranes, right? So any of your reusable intubation equipment could be used here. Then you have your intermediate level. This is where we kind of fall in. This is where we're using, right? You're using bleach, you're using those purple wipes on stuff that tells you what it's going to get rid of, but it will not necessarily get rid of bacterial spores. This is anything that might come in contact with your intact skin, right? So your ambulance bench, the oh shit rail, etc., etc. And then you have low-level disinfection, right? This is like I kind of use a little Lysol wipe on my house. Routine house cleaning if there's no blood, like just generalized disinfectants. We talked about the immune system last week, so we're not going to go into this much, but hey, vaccines are good for you. We mobilize your body to produce antibodies so that it can fight things. So, pathology of infectious disease. So, first of all, in order for an infectious disease to become infectious in your body, it needs to have a number of components. First being virulence, right? It needs to be like a virus or bacteria, or it has to have some sort of negative effect in your body. Then it must be a dose, right? So if I only get one viral microbe or one virus into my body, my immune system is going to do a good job of taking care of it. But if I walk through a cloud of COVID, I am very much at a high dose of virus. So I am more likely to get sick. Then you have resistance, vaccinated versus unvaccinated. Have I developed some level of immunity to this before by being exposed, right? So we have a certain level in healthcare. Health kind of had a certain level of resistance to COVID in general because we've all seen coronaviruses in the past. Our body's like, oh, this is kind of familiar. It's a little different, but it's kind of familiar. Then you have to have a host. Congratulations, you are the host. You have to have, a body where the virus decides it's going to set some roots. And then there's a mode of entry, right? Most of the time, this is mucous membranes. This could be your eyes, your nose, your mouth. It could be a cut or non-intact skin. Okay, anything where your continuity of safety is not in place. So then, on top of that, you also, in order for viruses and bacteria to become an issue, is they need a portal of exit. This is like sneezing, coughing, okay, bleeding on stuff. That's your portal of exit. So round and round it goes. Where it stops, we still don't know when COVID's going to be done, so I guess we don't know. So a pathogenic agent is something that causes disease in a human host. There are some viruses and bacteria that will not create disease in a human host, okay, because it's just not compatible. Maybe it's a virus that only causes sickness in a cat, okay, or a dog, or a rat, okay. So sometimes there's not zoological compatibility between organism and host, but like a mosquito can have malaria and pass it on, and the mosquito's not going to get sick, okay. A mosquito's not going to be in bed with a blanket and a thermometer. But these bacteria, and sometimes the bacteria will need to have a way to live outside of a host. Viruses are different, where they're not technically alive. They're just a bit of RNA in a capsule that then hooks up with a host and takes it over. So the agent can be classified by a number of different things. Shape, right? Chemical composition, growth requirements, viability, right? So virus hepatitis B looks different than hepatitis C. Different bacteria look different. They have gram-positive, gram-negative bacteria, right? If they stain or on a microscope slide or not. So bacteria are relatively susceptible to antibiotics. We are in this day and age creating a whole slew of antibiotic-resistant bacteria because people aren't finishing their course of antibiotics when they are sick, and they are also over prescribing bacteria. Viruses, on the other hand, as I said, are not really living. They're harder to get rid of because they're just this little capsule of RNA that when it gets inside of a body, it hooks up with a normal body cell and then starts to replicate inside of it, and then meshes with the DNA, and then that's how it replicates and spreads and spreads. There's also funguses or fungi and parasites that are around as well, but we really focus on those two because they're the most common. So the agent needs to be able to get inside of a host and reproduce. And then it needs to be able to reproduce at a rate where it will actually cause infection, right? So if you have one bacteria kind of reproduces every other day, you're not going to have an issue because your body's going to be like, bro, you don't belong here, and kind of evict it. This is, we talk about in Staphylococcus, right? Does it produce a toxin? If it produces a toxin, that toxin can cause more damage than the bacteria itself, okay? Because it can cause things like tissue damage. How potent is it, right? Is that pathogenic agent going to survive well based on the immune response from the host? Is it going to be able to reproduce quickly? All of these things take into account how well a disease spreads. Pathogens live within a reservoir, so it could be food, it could be a host such as a bug, and you might be sick at any given time and be completely asymptomatic and just carry it. Like, again, a lot of these things I feel like are relatively familiar now that we've just gone through a pandemic, but we have those patients who are symptomatic and those who are asymptomatic. There are some illnesses where if you are asymptomatic, you can't or won't necessarily spread it because the viral load is too low. You need to have a certain amount of viral load or bacterial load or whatever to spread it to someone else. There's your portal of exit, sneezing. Okay, fecal oral route, right, could also be through the GI system. Open wounds, right, this is why we wear gloves and PPE, but this is how it leaves in order to invade another. Also mode of transmission, okay, right, so are we making direct contact, right? Mono, kissing. Indirect contact, I can spread a bacteria or virus through sharing cups or something with someone else. Food, okay, that fecal oral route we talked about. The mosquito or a rabid animal, this is the vector borne, okay? So it depends on a number of different things and how the virus and or bacteria is spread. So there's a number of different ways that a pathogenic agent can enter the body. Most of the time it's broken skin, insect bite, or mucosal membranes, okay? All of those things are a number of different ways that can cross into the body in order to get an infection. This is part of the reason, like pregnant women, they'll check them for staph B around their vaginal and anal openings because when a baby is born, they have those open eyeballs, right? They have a mouth. Those brand new mucosal membranes, they can get very sick. And then how susceptible, yep, and herpes. How susceptible are you as a host to get sick, right? Are you kind of stressed and run down? Like everyone right now in paramedic school, y'all are probably really susceptible to getting sick. Not only are you in a field where you are going to be potentially regularly exposed to different pathogens, but you're tired. You're maybe not eating great, okay? All of those things make a big difference in regards to how you can fight off getting sick. Here are some things. I'll let you read them while I have it. All right. There we go. Human response to infection. Right, we kind of talked about this a little bit already when we talked about immunology, which really these two should kind of hang out together a little bit closer. I don't make this all this. So your very first line of defense is obviously your skin and mucosal membranes. For the love of God. Hold on. You have about 100 trillion bacteria living on your body, in your gut biome, etc. Um, they do a very good job of keeping you relatively healthy most of the time. With the influx of antibacterial soaps and such, we are kind of doing a little bit of a damage to our own flora. We need that. Okay, they do a really good job of keeping us safe because they're competing with these other bacteria. So if you get like a pathogenic bacteria on your skin, the regular flora is over there like, yo, bro, you don't belong, and kind of fights it and gets rid of it. So if we damage our normal flora, we can do damage to ourselves on a larger scale. Intact skin, right? Number one line of defense. Same thing with the GI system. We have all of those normal flora living in there. Stomach acid does a really good job of destroying bacterias that don't belong. Okay, so if you eat something that bacteria and viruses that don't belong, pH of 1 is not a super habitable place to live. So, you know, does a good job of keeping us safe. And then everything that's also bad goes out through the feces. And the upper respiratory tract, right? The very first line of defense is your nose hair. Okay, it captures a lot of stuff, right? Boogers are good for you. That's your body getting rid of all of those bacteria and stuff that you may have, inhaled, or like a cloud of germs that you've walked through. Anything that your body constantly pushes up, different levels of mucus that are in your upper respiratory tract, and then you either swallow it, cough it, or sneeze it. So at any of those ways, it's getting that bacteria or those pathogens out of your system. You're also your tonsils, right, do a pretty good job of also having a pretty rapid immune response because they're right at the gate of entry. Same thing with your urinary tract, right? Your body is not super habitable there because of pH derangements that are not really good for bacteria. And your body, a constant flow of urine helps kill bacteria to prevent infection. We talked about this already. I'm not going to go in deep with this, but you have your various inflammatory mediators. Okay, every part of your body works to protect you. So you'll have a local reaction before you have a systemic reaction. But when your inflammatory response happens in one single location, so if I hurt myself in my hand, I have that isolated location, it will send, all of these inflammatory mediators, infectious mediators to that site to prevent it from getting worse. So the different stages of disease. So your very first is the latent stage. The pathogen invades the body. At this stage, you may or may not get sick. You can though spread it. So if you have a little bit of something going on, right? You feel a little scratchy throat or whatever. If you're coughing, sneezing, or whatever, depending on what kind of pathogen you're infected with, or you're latent with, excuse me, is how it's going to potentially be spread. This is determined by a number of different factors, right? Which pathogen it is. And then when you have your incubation period, again, it's different for every virus or bacteria that you have. When you have your latent stage to your incubation stage can be anywhere from a few days to a week to be, depending on what kind of infection it is, could be years. Whatever that pathogen is, it starts to reproduce and either spread or produce an antibody production. If it produces an antibody production, your body might be able to get rid of it before it actually causes disease. Again, after your incubation phase, the disease phase can vary in duration depending on not only disease, but your health status prior to being sick. You may or may not have actual symptoms. If you do not have symptoms, you are considered asymptomatic. Viruses, for the most part, become incorporated into the body. This is why things like chickenpox can come back as shingles later on. Okay, a lot of those can just kind of hide out within the body. So the first one we're going to talk about is HIV, human immunodeficiency virus. This is commonly sexually transmitted. from person to person contact. It can also be transfused through contaminated blood, needles, and syringes. HIV has been experiencing what they call a graying in this country because they have figured out how to control the virus to such a degree that it's almost completely asymptomatic. They get the viral load so low in infected patients that they have very, very low chance of actually spreading it to others. And because of that, a lot of the research on actually curing it has also ground to a stop. However, we have been seeing a lot of positive solutions for HIV. So if you're really not sure what HIV is, go watch the movie Rent, and you'll be fine. Again, unprotected sex. Unprotected sex is just like not a good idea, clearly. Don't share needles with people either. There is a very low risk to you as a provider from a needle stick, but from a contaminated one, you do need to make sure that you do follow your infection control procedures. But you need to make sure that you're minimizing your risk. A lot of the patients who have HIV, you would never even know that they have HIV because again, as long as they take their medications properly, they keep the viral load so low that it doesn't even show up on blood work. It is a retrovirus, so it constantly makes itself, it seeks out T cells. We're not going to talk much about how the HIV virus reproduces, but it's considered a retrovirus. Viruses commonly just commandeer other cells and make more virus. Okay, so if it can't find a CD4 molecule on a T cell, it can't get into a cell. So this is part of the way that the medications for HIV work. It keeps the virus from being able to enter the T cells in general. HIV doesn't kill patients. AIDS and the secondary complications are really what kills HIV patients. There's a lot of different things. Most of the time it's pneumonia. Pneumonia kills most HIV/AIDS patients. Fungal infections, cancer, HIV encephalitis/dementia. Okay, right? So it's sort of like kind of wasting away. But again, if your patient's taking their antiretrovirals and they're taking their medications properly and don't miss doses, they won't necessarily have any symptoms or other secondary complications. Here's a fun picture. Just like including in my slide. Usually HIV will have a 2 to 4 week acute infection afterwards where a patient will present with a low-grade fever, flu-like symptoms, and will have a brief decrease in their T cell count. If they do progress all the way to AIDS, which is autoimmune deficiency syndrome, the T cells have been completely wiped out, okay? Which means that you cannot fight other infections, and you're just like constantly sick. And this is why people die from pneumonia. The clinical latency stage is any number of different periods. Again, antivirals, the antiretrovirals do a really good job of keeping less sick. So HIV can also cause, because of its attack on the immune system, causes accelerated aging, right? So this is why patients will end up with the dementia issues or bone density problems. But again, all the new pharmacological treatments have done a really good job of reducing AIDS in general, as well as the number of patients who are dealing with HIV. It's become more of a chronic illness that's manageable with medication rather than an absolute death sentence. Always wear your PPE. a lot of times patients won't necessarily tell you that they have HIV, and you'll find out later from their history at the hospital. So just make sure that you protect yourself well in the beginning of your call, every call. Patients will need to have a very high viral load in their blood in order to spread that. This is why those antivirals are so potentially helpful. So I think the Tracy Allen Lee was the first woman who she ended up getting HIV from a HIV infected patient. Ended up dying 3 years later because New York City decided that they were going to deny her line of duty death or line of duty injury benefits. So she decided that rather than be taking a lot of medications and being miserable for the last years of her life, that she was going to actually enjoy it. So she actually, the reason that she died so relatively quickly was because she, decided to live life instead of being on the medications, which weren't that effective at that time. Go weigh your stuff. Go watch Rent. Notify your infection control officer. The source patient will be tested. There is a really delightful cocktail of things that they'll treat you for, your PEP, post-exposure prophylaxis. Okay, so HIV, they'll put you on antiretrovirals. Hepatitis B, they'll give you a vaccine. TB, they'll do quantiferon testing and a chest x-ray after they give you like a nice cocktail of medications. You should know that these are your PEP, like what the PEPs are. Mostly hepatitis B. That's usually a question you see. Hepatitis, right? Inflammation. In order to get hepatitis E, you must have A. In order to get hepatitis G, you must have A. It's like a weird monopoly hepatitis. In order to get hepatitis D, you must have hepatitis B. Hep C just kind of hangs out by itself. It's antisocial. There is no vaccine for hepatitis C. However, there is an antiviral treatment that has been found in the most recent years to be very clinically significant and help remove the virus from the system. Hepatitis A is probably the most common. This happens through the oral fecal route and does not lead to chronic liver disease, whereas B and C can and usually do. So you'll see jaundice and stuff like that in B, and you might have transient jaundice in A during the actual acute phase of the infection, but it usually pretty much self-resolves. Hepatitis C can be managed through medications and stuff as well if the patient does not qualify for whatever their new antiviral treatment is. Hepatitis B is usually you get more sick. Most Hep A infections is just kind of like, oh, you've had it, oh, you're better. Illicit drugs also have that. Anywhere where they don't do really good hand washing, especially in food preparation, you have an increased risk of hepatitis A. But once you have exposure to hepatitis A, you are good for life. Hepatitis B, well, we spent a lot of time focusing on HIV, which is kind of becoming a non-issue at this point. Hepatitis B is way, way more infectious, mostly because it can live in dry blood for 7 to 14 days, or 12, I think it's 12 days. This is why we do a really good job of making sure we disinfect all of our equipment after use, and our ambulance as well. Most of the time, this is through needle stick issues. Tattoo and body piercing was an issue for a while, but there's very low, depending on where you go. If you go to a licensed tattoo body piercer, they're required to have single-use needles now because of hepatitis B. It can be spread through the placenta as well to developing fetuses. It can really jack up your liver. Okay, so most of your viruses will present with flu-like symptoms, the body aches, fever, cough, but depending on where the infection is, right? So hepatitis, you could have jaundice, pancreatitis, clotting issues, right? Because your liver does all your clotting factors. You could have all those problems there. Tuberculosis, yet again, kind of a disease that is being relatively phased out. Most other countries have a tuberculosis vaccine. We do not in the United States because it is not considered a public health crisis. Patients with tuberculosis are commonly found in cramped living quarters. Okay, it is a bacteria. It is droplet spread. So even if you can have been exposed to TB, never develop a TB infection, but your body can, you will then potentially test positive to a PPD. Most places aren't even doing PPDs anymore because quantiferon is the gold standard, and there are some places that aren't even doing the quantiferon because they haven't even had a tuberculosis case in such a significant number of years that it's not worth it. But TB can and cause inflammatory lesions throughout the body, primarily in the lungs. There is skin tuberculosis also, which is usually seen in is commonly seen in Native American reservations. Sorry. So signs and symptoms of tuberculosis usually of patients from shelters are at increased risk. Patients will have no appetite. They'll experience night sweats. Okay, they'll have a cough most of the time with blood. They'll have a fever, chills, all sorts of different issues. But again, not something that we see all that often, but one of those diseases that they kind of harp on in the literature. So you should be more familiar with HIV and tuberculosis because that's the only things they decided to write test questions for. Disinfect your equipment. Okay, tuberculosis does have a number of medications that they use to treat it, but you will lose about 15 pounds on that medication. It is not a good medication. It's rough. You can't drink alcohol. You can't. There's a lot of issues to it because it really kind of screws up your liver. Good ventilation in the ambulance. That's why we have those fans. Make sure you wear your N95 if there's a possibility of tuberculosis. These patients will end up going to a negative pressure room if they are being transported. And if there's a negative pressure room available, because I think they're all currently full of COVID patients. All right, bacterial meningitis. Bacterial meningitis is commonly, bacterial meningitis is more deadly than viral meningitis. It is a bacterial infection of the membranes that line the brain and spinal cord. It is commonly caused by N. meningitidis. Most of the time, again, close spaces, direct contact with infectious upper respiratory tract secretions. So this is why when kids go away to college, they're required to get a bacterial meningitis vaccine because bacterial meningitis will move quickly and it will kill you within a few days because your brain doesn't like that. By a few days, I mean from when you first become exposed to when you are dead. But it is very debilitating. It's very bad. Very high fevers, altered mental status, overall not good. Meningococcal meningitis is caused by N. meningitidis. I'm getting really good. Droplet precautions, okay. If you have any potential exposure, they will give you prophylaxis medications. S. pneumoniae is the most common cause in infants, children, and older adults. Most of the time, it starts in a like an ear infection and then spreads. Whereas group B, streptococcus, is the most common cause of meningitis in newborns during vaginal birth. Okay, this is why they test mom for strep B during her prenatal visits because they want to make sure that they're not going to inadvertently get a child bacterial meningitis that will kill them almost instantaneously. It's just overwhelming for a new baby. It's very, very poor outcomes if they do end up with this. And again, streptococcus and a lot of these bacteria just kind of live on your skin and could be around and you will never know. Kernig sign and Brudzinski's sign. The first one is up top is the Kernig sign. The patient will not be able to flex their knee like that. Whereas Brudzinski's sign, if they cannot lay flat and take their chin to their chest, is called nuchal rigidity. It's a very positive, sensitive sign of meningitis because all of those membranes, remember down the spinal cord, are highly inflamed. So once you try to do this, you put too much pressure and your body tries to make your spinal cord or reduce the length, give you more spinal cord to bend your neck. Viral meningitis, usually self-limiting, okay? Patients will have very similar signs. They might have nuchal rigidity, headaches, blurred vision, fatigue, a lot of flu-like symptoms, but you just want to look for those specific issues, such as that nuchal rigidity and the headaches that might be going on. Patients with meningitis also will have higher fevers than you would expect in a regular old kind of run-of-the-mill virus or flu. There are vaccines available for meningitis, right? So this is what they usually give to kids who are going to go live in a dorm. This is also for people who are potentially living in nursing homes, right? Or the older group still living. They want to make sure that they're not going to spread this to a lot of people. Patients who are living with severe comorbidities like bad diabetes, heart disease, etc., are also usually qualified for pneumococcal vaccines. Bacterial endocarditis, this is an infection of the inside of the heart, primarily the heart valves. Okay, heart valves are very much at risk within the heart. A lot of the time, the bacteria is dislodged from somewhere else in the body, primarily dental work. Okay, this is why a lot of, as you get older, they will give you prophylactic antibiotics before you go and get like a deep cleaning at the dentist, because they don't want to send that bacteria down into your heart. It's also very common due to IV drug use. Okay, this is like the young patients who you see who have, artificial heart valves, is because they've given themselves bacterial endocarditis from their drug use, and now they, in order to live, needed a heart valve replacement. Collectively, it is also more common in older men, but there's a lot of different reasons that bacterial endocarditis can happen. But again, the most commonly it's IV drug use and dental work where it spreads. These are called Janeway lesions, or little dots on the hands, those little kind of cool symptoms that you might help you identify endocarditis in a patient. Splinter hemorrhaging under the nails, you can see on the bottom. Kind of non-specific, right? A lot of the times you're not going to necessarily be diagnosing these, but you should probably be familiar with some of the terminology like Janeway lesion. Pneumonias, all right? This is by far the most common infectious disease that you're probably going to see in the field. Pneumonia is anything that is in the lungs that is not air, okay? It could be due to toxic exposure. It could be due to bacteria, smoking, aspiration, cancer, almost anything, okay? If it's in the lung and it's not allowing the lung to do lung things, it's most of the time considered to be a pneumonia of some sort. In the bacterial realm, it can be spread through droplets, okay? Respiratory secretions, all of those things. Most of the time, a good indicator that a patient has pneumonia is you'll hear the lung sounds. They'll have a combination of bronchi and potentially rales. They'll have a productive cough with colorful sputum, okay? They might be short of breath. They might have a fever. But the problem is, as the patients start to get older, the symptoms become a little less specific. So they might just be kind of like fatigued, or they might have altered mental status, or they might have a UTI that has elevated or escalated through the body and ended up in the lungs. So there's a lot of different reasons that a patient can get pneumonia, but you need to make sure that you're taking all the different pictures of the history and finding out what's going on. Also getting really good lung sounds. Okay. A problem is once that infectious material gets down there, it can either cause like a fluid in the alveoli, or it can start to what's called consolidate. Especially, you lose a lot of fluid through respiratory secretions, just normal breathing. And if you're sick, you're breathing harder, which means you're losing more fluid, and that mucus and that pus is going to start to get dehydrated and turn to almost like cement in the lungs. find that with patients who have pneumonia, giving them a little bit of fluid starts to make them feel better because it loosens up that junk that's in their lungs and it gets a little bit more mobile, so they start to feel like they're breathing a little bit better. Tetanus, okay? You are probably most likely vaccinated for tetanus. If you can't remember the last time you got a tetanus shot, you probably need a booster about every 10 years. Tetanus is relatively rare, but is spread through spores, and it paralyzes nerves that control your muscular control. So it causes what's called tetany. Most commonly is called lockjaw. So that picture on the bottom is lockjaw. It also causes severe muscular contractions, and it can get so bad that it actually causes respiratory failure. Tetanus is actually the Clostridium tetani spores. Is Nope, wrong disease. Never mind, ignore that. All right, so tetanus, get your booster shots. It's very rare because of booster shots. Every time someone has some sort of traumatic experience, they will give you a tetanus booster as long as you are like, if you're unsure as when your last booster was, because a lot of people don't really remember. Rabies. Rabies is a viral infection transmitted through the saliva of animals. Okay. Possums are completely immune to rabies, so don't be afraid of possums. Other animals, however, are carriers. Not only bats, which always get a bad rap, but dogs, woodchucks, because they could not only just chuck wood, but they will also chuck rabies at you. Coyotes, any animal that you see that's acting abnormally or is outside its normal habitat, you should have a high index of suspicion for rabies. Rabies will progress and become this a central nervous system issue where you start to developing like hydrophobia, like so you won't be able to drink water, but you'll be extremely thirsty. While the incubation period might be really quickly, where you'll develop rabies really quick, it also could hang out in your system for a very long time before it actually shows any issues. But it ends up going and infecting your brain. There will be a low-grade fever to begin with. That hydrophobia, right, where they're afraid of water, but they're really thirsty, is part of the reason that they end up with that that rabid foaming at the mouth. They usually will give, if you do have an animal bite, especially if this is why dog bites, they want to know if you know the patient or know the dog, because if the dog's up to date on their rabies shots, you don't need to get a rabies shot. You don't need to get that prep. But if they are an unknown dog with an unknown vaccination status, you might end up needing the prophylaxis on your own. Here, some. Right, so here in the eastern seaboard, we have to watch out the most for raccoons, as well as bats, in terms of those who will give you rabies. Watch out for those guys. Safe in a lot of other places. Afraid of rabies. So the hantavirus is transmitted by rodents, okay? But it's aerosolized fecal and urine, or fecal matter and urine. So if you happen to be out cleaning your garage and you find a rat or mouse nest, and you start to disturb it, this is where you put yourself at risk for developing a hantavirus. There are two types, the Asian type and the American type. The Asian type is associated with hemorrhagic fever, a la Ebola. Okay, so it'll start attacking your blood, as well as your kidneys. And then you have the United States, which is the United States hantavirus, which is severe respiratory distress and shock. So most of the time, it's caused by, as I said, rodent droppings. Of the, I believe it's the Blackfoot mouse. I have pictures. I know I have pictures. So usually patient, you'll be, cleaning up somewhere where it may have rodent infestation, and all of a sudden you have some respiratory distress, fever, malaise a few days later, capillary hemorrhaging, upset stomach. If it gets really, really bad, it can progress into kidney failure. Here you go. It's the deer mouse. The deer mouse, which is a very common mouse almost everywhere, is the one that traditionally carries the hantavirus. Your house mouse is safe. You can obviously, well, I'd be more likely to tell the difference between mice than the snakes because when we get to environmental concerns, they're always like, well, what kind of snake was it? Like the slithery type. I wasn't going to go ask him his name. Mice, on the other hand, I'm okay with. Um, they have two-toned fur, in case you're wondering. They have a white underbelly. House mice are just one color. Rats are larger. And then you have the roof rat, the brown rat, or the black rat, the brown rat, and then the subway rat, which is usually carrying pizza. So you just have to watch out for those guys. Then you have your mosquito-borne illnesses. We had such a delightful combination of new mosquito-borne illnesses a few years ago, including Zika. Right? There was causing all sorts of issues, reproductive issues. Best thing to do is wear personal protection such as bug spray, insect repellents. Mosquito netting is great, especially if you know you're going to be in a place with a lot of mosquitoes. And reducing mosquito habitats, which is standing water. So if you're one of those asshole neighbors who has standing water, dump it out, please. Mosquitoes also like tall grass because mosquitoes are actually the #1 pollinators of grass. They actually do serve a purpose other than being annoying. There are no vaccines for many of the mosquito-borne illnesses that are out and about. But let's talk about them. So I can't even say this first one. Hold on. Chikungunya, fever, joint pain, swelling, rash, pain, myalgia is just pain. Okay, if people who are coming back from an affected area may present with this. Dengue fever is very rare in continental United States. It's more common in a lot of these mosquito-borne areas are more common in tropical regions because mosquitoes have just more fun. Dengue fever has like a very high fever, and usually there'll be 2 other symptoms associated with it, such as a severe headache, a joint pain, rash, a low white blood cell count. We have West Nile, right? That's common in the United States. That's something you should be relatively familiar with. Again, the patient will develop a fever, headache, myalgia. A lot of these viruses are your flu-like symptoms. The Zika virus was resulting in birth defects such as microcephaly. And they also found that Zika virus could be spread sexually, which was wild. Okay, that was fun. I remember that. Same thing. You're going to have a lot of the fever, headache, myalgia. The one that really needs to be kind of, I guess, separated from these is malaria, because malaria is not a virus. Malaria is actually a parasite. When you're going to places that have high risk of malaria, they will have you take whatchamacallit. They were fake using it COVID for a little while.
Doxycycline.
No, not doxycycline. They use it for autoimmune diseases, but it's actually an anti-malarial drug. I'm sure it'll pop up somewhere in my slides. But again, a lot of times will be kind of vague flu-like symptoms. The problem is that when you do a blood
Nicole, I think it's hydroxychloroquine.
Yes, hydroxychloroquine. Thank you. It's not ivermectin. There's
I
another one
think
with
it's
an
also
I.
used to treat lupus, no?
Yes, they use hydroxychloroquine is an anti-malarial drug, but they use it for autoimmune diseases such as lupus, off-label because for some reason it works. They don't know why. But yes, thank you. So the parasite can get into the brain and a lot of the rest of the organs, the vital organs, and cause all sorts of issues. So malaria needs to be dealt with a little bit different than a virus. It actually does need antiparasitic medications. So I kind of mentioned this a little bit before, but because people aren't finishing their courses of antibiotics and they're not and we're overprescribing antibiotics, we have caused a good number of bacteria to become drug resistant. The most common ones that we're seeing are C. diff or Clostridium difficile, which is a GI bacteria. An enterobacteria. That's this one. Gonorrhea is a form of gonorrhea that is drug resistant. There's MRSA, right? So just blanked on that one. But C. diff, you commonly see patients dealing with C. diff in like an older generation or older community. They most of the time have been just finishing an antibiotic therapy for something else. C. diff usually lives in your intestines, but if you take antibiotics and kill off the stuff that keeps the C. diff in check, then it becomes a problem. C. diff has a very specific and identifiable odor. Okay, it causes severe diarrhea, like life-threatening diarrhea, because the patient is losing so much fluid from this diarrhea that they can become extremely hypovolemic. The problem with C. diff is it produces spores. Spores need to be removed through hand washing. Okay, C. diff is actually, yes, thank you, methicillin-resistant Staphylococcus aureus is one of the other common ones that we see. So you need to make hand washing for the spores, because otherwise you will fecal oral route. CRE is a urine, usually shows up in the urine. It's hard to treat. A lot of patients when they get CRE, they will die. Klebsiella and E. coli are up there also in this antibiotic area. Contact precautions. These patients end up usually on will end up on long-term antibiotics to kind of try to keep it steady. Drug-resistant gonorrhea, because your sex life can get worse. MRSA is also very popular as a medication. Muprosin is commonly used for MRSA infections as a topical. Almost every single healthcare worker in the United States has MRSA somewhere. It might be under your fingernails. It might be colonized in your nares. You've been exposed to it. The problem is when it gets out of control, because your body's pretty good at keeping it in check. It will allow it to colonize. So you'll have like a little spot and it just lives there. But that's it. We are seeing a bit of a rise in some of the infectious diseases of childhood because people don't want to get their kids vaccinated for shit that should have been gone a long, long time ago. One of my former medic students was working in a clinic in Wisconsin as a contractor, and apparently he's been seeing a bunch of measles so far. So vaccinate your kids, because they will die from some of these things. Rubella is also known as German measles. Droplet contact or droplet spray is usually what spreads it. These patients will have like this macular rash. Okay, so they'll have that like chicken poxy kind of rash, but if you push it, it doesn't blanch. Okay, so it stays red. Very communicable. It can also cause blindness in children. This is the bigger problem with German measles, is that if it gets passed to her unborn child, especially during gestation, the baby will be born potentially very blind, deaf, or have a number of other congenital issues. Then you have rubeola, which is just your regular old non-German measles. Again, pharyngeal secretions is probably the easiest and most communicable way of it being spread, but it's also transmitted by blood and urine. Fever, conjunctivitis, upper respiratory infections. So the blotchy red rash of measles is usually around on the 3rd day. Okay, so of the patient being sick. Same thing, those little red spots are not going to blanch. And the difference between like measles and chickenpox, or the two different types of measles and chickenpox, is usually the stage. Chickenpox will have the rash will be in different stages of healing during chickenpox, whereas measles are all kind of around the same. Back in 2019, there was a really delightful outbreak of measles, particularly in Kings and Queens County in the Hasidic Jewish area. It was very highly hit. Also in Rockland County. That was kind of the primary location of those outbreaks. They were shutting down schools and such because of it. Mumps, another viral disease. The mumps will cause the salivary glands to become very, very swollen. So you can see here in this kid, he's got a bad case of the mumps, where it ends up swelling up that parotid gland. Again, saliva contact, droplet contact, affect the pancreas and other glandular tissue such as the testicles. Chickenpox has a very useful vaccine now. Back in the day, they used to have chickenpox parties to make sure that everybody got chickenpox when they were a kid, and that was how they vaccinated. Now we have a actual vaccine, which is nice because chickenpox can turn into shingles when you're older. Again, it's a respiratory droplet and/or vesicle. The discharge from the rash can spread chickenpox. Usually, it's a low-grade fever, a little bit of malaise, and then all of a sudden the skin eruptions, and then you have to go take a nice oatmeal bath. So here's the different stages of healing, right? So it's about a two-week lifespan for the rash. So this is shingles, right? So we talked about earlier how the virus can live in your body and just kind of hang out somewhere. And this is how chickenpox or the varicella virus or the varicella zoster virus becomes shingles later in life. So if you had chickenpox as a child, that virus will live in a dermatome, right? That picture where you have that one nerve that's innervating that certain area, right? And like layers along your body. It will find a dermatome and it will set up camp. And then at some point in the future, there's a possibility that you're feeling very stressed or you have a certain level of immunosuppression. That virus will take advantage of it and spring back to life right along the dermatome in shingles. Shingles is extremely contagious, but only if it's in contact with the open skin lesions. I had a patient once who had shingles straight across his eye. Okay, it can be extremely uncomfortable. It's extremely itchy, extremely painful, and doesn't have like a nice little 2-week lifespan like chickenpox does.
Nicole.
Yes.
So I had shingles when I was 19 years old from an exposure on the ambulance. Nobody knew, and I never had chickenpox. I got the vaccine as a baby, and it can also mutate from that. Which my doctor was like, no, this isn't shingles. I was like, okay, feels like shingles. 2 days later, oh yeah, you have shingles.
Thanks, bro. Very good to know. So yes. So I think it's also that if you've had the vaccine, the chickenpox vaccine, then obviously you can skip right to shingles. That sucks.
Yeah. It was on the left side of my face. It actually was near my eye and just went.
Oh, that
right
sounds
there.
absolutely miserable.
Yeah, it was great. Good times.
So you have pertussis or whooping cough. This is very dangerous for children because once they start coughing, they aren't going to necessarily going to be able to get breath in, right? Kids need to breathe. Kids are very respiratory driven. So this is why whooping cough can be very, very deadly for little kids. This is why they encourage anyone who's going to be around a newborn, parents, grandparents, etc., to get the pertussis vaccine to help prevent that little baby from getting sick and dying. Pertussis, and aka whooping cough, has a very distinctive whooping steel bark kind of cough, like whoop whoop whoop, right? It's continuous. It is so much inflammation in the respiratory tract that it just is very violent coughing, and it's very hard to stop once the patient starts getting going. Other common childhood diseases, RSV or wow, I've been saying respiratory syncytial virus. There we go. I've been saying for like the last 3 days. I'm just blanked on what it is. Very, very common. Most common cause of upper respiratory tract infections in young children. it's like a mild. It can be very mild, but if the child is sick with something else, that RSV can be deadly. Just like almost any other disease. Again, droplet precautions. Croup, viral infection of the upper airways, that seal-like bark that okay, patient will have a low-grade fever. And then you have epiglottitis, which is very high fever, usually late at night. Patient will have a sore throat, hoarseness, and will be drooling. Remember drooling, okay? Drooling is usually the definitive test question answer between what's the difference between croup and epiglottitis. So croup, not too bad. Patient can be sick. Usually epiglottitis comes on suddenly, very high fever, and drool. The flu, droplet. A lot of these are also droplet precautions. There's a number of different flus. Mutates very rapidly, so we will have, the different flu shot every year. SARS, in case y'all forgot about what's going on recently, SARS is brought to you by the coronavirus. There was an outbreak in 2003 and 4. We have another new one now. Fever, muscle aches, pneumonia. And then mono. About 80% of the population has had the Epstein-Barr virus, aka mono, before the age of 5. Usually it's spread through daycare. And you never know that the kid had it because they'll have just like a kind of generic flu-like symptoms, cough, fever, sore throat for a few days, and then they'll go right on with life like nothing ever happened. When you get mono a little bit older, it can strike you a little bit harder. There are some strains of the Epstein-Barr virus which will do a chickenpox shingles kind of vibe and will repeat, and can have a recurring mononucleosis infection. Mononucleosis has also been linked to chronic fatigue syndrome and multiple sclerosis. Wrap it up. Sexually transmitted diseases, they're no fun. So one, you have syphilis. Most of the time, syphilis, if it's not caught, can cause significant issues with, like mental impairment, psychosis. Most of the time, if it's not noticed, there's usually a sore associated with syphilis. If it's not noticed in the first 90 days, it can result in a body rash. And if you're one of those stubborn people who don't go to the hospital or go to the doctor and get this relatively easy to treat infection taken care of with some antibiotics, it can turn into a full internal organ fiesta. Okay. Remember, it usually starts with a sore. It can end, and then it usually ends with a sore. They're called gumma. Right. So it's the Chancre lesion is the first primary. It usually ends up on the genitalia. Gonorrhea. We talked about how it can be now antibiotic resistant, but it will potentially present with a lot of like UTI-like symptoms. Additionally, with some discharge, treatable with antibiotics, can spread systemically through the blood. Testicular swelling is also a possibility. Just send this link to you. Then there's chlamydia. I believe it's the most common STD in the United States. Ironically, chlamydia is most commonly found in nursing homes because they don't have to wrap it up, because they could just do what they want and don't have to worry about pregnancy. Those elderly. It can cause, again, a lot of the same symptoms as gonorrhea, where there's burning, painful urination, discomfort. Again, it is associated with discharge, but if it's not treated, it can untreated can lead to also pelvic inflammatory disease. Herpes has a couple of different brands. So, for example, chickenpox is a herpes virus, the herpes zoster. Then you have herpes simplex 1 and 2. Usually, 1 is usually above the waist, is cold sores. 2 is usually below the waist and is genital herpes. Most of the time, this is caused, it's spread through skin-to-skin contact, and stress and other things can cause an outbreak. Lice and scabies, bleh, things that make you go itchy. Lice are commonly found in the upper hairs. Okay, they suck blood. They leave a little macule. Okay, and itchiness from feeding. I can't look at this picture anymore. Pubic lice, on the other hand, look like little crabs, hence why they're called crabs. They tend to live on the pubic hair, hence the name, but they can also spread to other body hairs. Okay. If you see stuff crawling on your patient, don't mess with it. Here you go. Head lice are longer than pubic lice, which look more like crabs. Scabies are also very commonly spread through contact. Okay, they're very commonly found in nursing homes and healthcare situations. They're these little tiny parasites that live their entire life on you. The disgusting part of it is that they'll burrow, okay? And as they burrow under your skin, they'll leave these like lesions, like you can see up here. That's a scabies burrow. And then they will lay their eggs there. And then about a month later, those eggs will hatch, and they'll continue going on and burrowing and feeding on you. They're itchy. They get. That's what I've got on that one. Not everybody's probably a little bit itchy. Questions, thoughts, concerns? All right, let me stop.